Welcome to this continuing education course on geriatric fall prevention, focusing on assessment and care. I'm glad you're here because falls represent one of the most significant yet preventable threats to the health and independence of older adults. Each year, approximately 1 in 4 adults aged 65 years and older experiences a fall, resulting in over 38,000 deaths and 3 million emergency department visits in the United States alone. The consequences extend far beyond immediate physical injury. Falls precipitate functional decline, psychological distress, loss of independence, and substantial healthcare expenditure estimated to exceed $50 billion annually. For allied health professionals working across community, long-term care, and hospital settings, the imperative to implement evidence-based fall prevention strategies has never been more urgent. The landscape of fall prevention has evolved substantially in recent years, marked by the release of the 2022 World Guidelines for Falls Prevention and Management and the 2024 U.S. Preventive Services Task Force recommendations. These foundational documents emphasize a person-centered, stratified approach to fall risk identification, comprehensive multifactorial assessment, and tailored intervention delivery. Critically, they underscore that effective fall prevention requires systematic screening of all older adults, with subsequent assessment and intervention intensity matched to individual risk profiles. Throughout this course, you will develop competencies in several key areas. You'll learn to differentiate among major fall risk factors and their pathophysiological contributions. You'll become proficient in selecting appropriate screening tools for diverse care settings. You'll master the components of conducting comprehensive multifactorial assessments. You'll understand how to implement exercise and environmental interventions with proven efficacy. You'll gain expertise in evaluating medication regimens for fall risk-increasing drugs. And you'll learn to apply implementation strategies that promote sustained adoption of fall prevention protocols. We'll conclude with clinical case studies that will challenge you to synthesize your knowledge and apply evidence-based decision-making to complex patient scenarios. The evidence is clear. Falls are not an inevitable consequence of aging, and systematic multidisciplinary fall prevention programs can substantially reduce both fall rates and associated morbidity. This course will equip you to lead and participate effectively in these programs, ultimately contributing to safer, more independent lives for the older adults you serve. Before we dive in, let me outline the specific learning objectives for this course. Upon completion, you will be able to identify the comorbidities that increase fall risk in older adults. You'll be able to select appropriate fall risk screening tools for specific care settings. You'll recognize the essential components of a comprehensive fall risk assessment. You'll identify effective interventions for reducing falls in high-risk older adults. You'll recognize fall risk-increasing medications using validated criteria. You'll apply strategies to integrate fall prevention protocols into clinical workflows. And finally, you'll be able to select tailored fall prevention interventions for older adults with complex needs. Let's begin with our first module, which covers the epidemiology and risk factors for falls in older adults. Falls among older adults constitute a global public health crisis with profound implications for individual health outcomes and healthcare systems worldwide. Understanding the epidemiology of falls, including their incidence, prevalence, and consequences across different care settings, provides the essential foundation for effective prevention efforts. Equally critical is a thorough appreciation of the multifactorial nature of fall risk, encompassing intrinsic physiological changes, chronic disease burden, medication effects, and environmental hazards that interact to determine an individual's vulnerability to falling. In this module, we'll examine the epidemiological landscape of falls in older adults, quantify the burden of fall-related morbidity and mortality, and provide detailed analysis of the major comorbidities and risk factors that contribute to elevated fall risk. The evidence we'll present draws from systematic reviews and meta-analyses published between 2022 and 2025, offering you the most current understanding of fall epidemiology and risk stratification. Let's start by looking at incidence and prevalence across care settings. The epidemiology of falls varies substantially across care settings, reflecting differences in population health status, environmental characteristics, and surveillance intensity. A comprehensive understanding of these setting-specific patterns is essential for appropriate resource allocation and intervention targeting. First, let's consider community-dwelling older adults. Among community-dwelling adults aged 65 years and older, approximately 25 to 30% experience at least one fall annually, with roughly half of these individuals falling multiple times. This translates to an annual incidence of 30 to 40 falls per 100 person years in the general older adult population. However, fall rates increase markedly with age. Adults aged 85 years and older experience fall rates nearly double those of adults aged 65 to 74 years. The consequences of community falls are substantial. Approximately 20% of falls result in injuries requiring medical attention, and 10% result in serious injuries, including fractures, traumatic brain injuries, and soft tissue injuries necessitating hospitalization. Hip fractures, occurring in approximately 1 to 2% of all falls, carry particularly grave implications. 20 to 30% of older adults who sustain hip fractures die within 1 year, and the majority of survivors experience permanent functional decline. Recent meta-analytic evidence has quantified these risks with greater precision. A systematic review of 87 studies encompassing over 500,000 participants established fall prevalence rates ranging from 11% to 42% across different populations and geographic regions, with higher rates consistently observed in women, those with previous falls, and individuals with multiple chronic conditions. Now let's turn to long-term care settings. Fall rates in long-term care facilities substantially exceed those in community settings, reflecting the higher burden of frailty, cognitive impairment, and functional dependency among residents. Systematic review data indicate an average annual fall rate of 1.5 falls per bed per year in nursing homes, approximately 3 times the rate observed in community-dwelling populations. Stated differently, the typical nursing home resident experiences at least 1 fall annually. A recent meta-analysis of falls in skilled nursing facilities reported an incidence of 121 falls per 100 person years, translating to more than 1 fall per resident per year on average. The outcomes of these falls are frequently severe. 10 to 25% result in fractures, 5 to 10% in serious head injuries, and approximately 2% in death within 6 months. Falls represent the leading cause of injury-related hospitalization among nursing home residents and contribute significantly to post-fall functional decline and subsequent transition to higher levels of care. In hospital settings, hospitalized older adults face elevated fall risk due to acute illness, unfamiliar environments, medication changes, deconditioning, and the presence of fall-precipitating conditions such as delirium. Meta-analytic evidence indicates hospital fall rates of 3 to 5 falls per 1,000 patient days among general medical surgical populations, with substantially higher rates of 8 to 12 per 1,000 patient days in geriatric, neurological, and rehabilitation units. The consequences of in-hospital falls extend beyond immediate injury. Falls during hospitalization are associated with prolonged length of stay, averaging 6 to 12 additional days, increased probability of discharge to institutional care rather than home, and elevated 30-day mortality. Systematic reviews have demonstrated that in-hospital functional decline, of which falls are both a cause and consequence, occurs in 30 to 50% of hospitalized older adults and predicts poor outcomes including mortality, readmission, and institutionalization. Now let's discuss the economic burden. The financial impact of falls on healthcare systems is staggering. In the United States, the direct medical costs of falls among older adults exceeded $50 billion in 2020, with projections suggesting costs will surpass $100 billion annually by 2030 as the population ages. These figures encompass emergency department visits, hospitalizations, rehabilitation services, long-term care placement, and ongoing medical management of fall-related injuries. Cost analyses consistently demonstrate that injurious falls, particularly those resulting in hip fractures or traumatic brain injuries, account for a disproportionate share of total fall-related expenditure. A single hip fracture generates average healthcare costs of $30,000 to $40,000 in the year following injury, and the lifetime costs of care for an older adult who sustains a hip fracture may exceed $100,000. Economic modeling studies have demonstrated favorable cost-effectiveness for community-based fall prevention programs, with combined multifactorial and environmental interventions, targeted vitamin D supplementation, and physical activity programs for women showing particularly favorable incremental cost-effectiveness ratios. Now that we've established the scope of the problem, let's examine the major comorbidities associated with fall risk. Falls in older adults are rarely attributable to a single cause. Rather, they result from the interaction of multiple intrinsic and extrinsic factors that accumulate with age and disease. Understanding the pathophysiological mechanisms by which specific comorbidities contribute to fall risk is essential for targeted assessment and intervention. We'll examine the 5 comorbidities with the strongest evidence-based associations with elevated fall risk. The first major comorbidity to consider is cognitive impairment and dementia. Cognitive impairment represents one of the most potent and clinically significant risk factors for falls in older adults. The association is robust, dose-dependent, and mediated through multiple pathophysiological mechanisms that compromise the complex sensor-motor integration required for safe mobility. Meta-analytic evidence consistently demonstrates that older adults with dementia experience fall rates 2 to 3 times higher than cognitively intact peers, with annual fall incidence of 60 to 80% in community-dwelling individuals with moderate to severe dementia. The risk is not confined to diagnosed dementia. Even mild cognitive impairment is associated with significantly elevated fall risk, with odds ratios of 1.5 to 2, and deficits in specific cognitive domains, particularly executive function and attention, predict falls independently of global cognitive scores. The mechanisms underlying the cognition-fall relationship are multifactorial. Executive dysfunction impairs the capacity for dual task performance, which is the simultaneous management of walking and cognitive processing that is essential for navigating complex environments. Individuals with executive impairment demonstrate characteristic stops walking when talking, behavior, and exhibit gait instability when confronted with cognitive distractions. Attentional deficits compromise hazard detection and response inhibition, reducing the capacity to identify and avoid environmental fall hazards. Visuospatial impairment distorts depth perception and spatial orientation, leading to misjudgment of step heights, distances, and surface characteristics. Delirium, or acute confusional state, warrants particular attention as a fall risk factor. Systematic review and meta-analysis of delirium and falls in community-dwelling older adults established a significant association, with a pooled odds ratio of 2.6, between delirium episodes and subsequent falls. Delirium is frequently precipitated by infections, medication changes, metabolic disturbances, and environmental transitions, all of which are common occurrences in healthcare settings. The interrelationship between delirium and dementia is bidirectional. Dementia predisposes to delirium, and delirium episodes accelerate cognitive decline, creating a vicious cycle of escalating fall risk. For clinicians, the key implications are that cognitive screening should be integrated into all comprehensive fall risk assessments, that fall prevention programs for cognitively impaired individuals require simplified, consistent interventions with caregiver involvement, and that delirium prevention and prompt recognition represent critical fall prevention strategies in acute and post-acute care settings. The second major comorbidity is mobility and gait disorders. Impairments in gait, balance, and functional mobility constitute the most proximate risk factors for falls, as they directly compromise the biomechanical capacity to maintain upright posture and execute safe transfers and ambulation. The strength of association between mobility impairment and falls is substantial, with meta-analyses reporting odds ratios of 2 to 4 depending on the measure employed and population studied. Gait speed, in particular, has emerged as a robust and easily assessed marker of fall risk. Walking speed below 0.8 to 1 meter per second is consistently associated with elevated fall probability, and the relationship demonstrates a graded dose-response pattern. Slower gait speed correlates with progressively higher fall rates. Umbrella reviews of fall prediction instruments have concluded that while no single gait, balance, or functional mobility measure predicts falls with high certainty in isolation, gait speed offers moderate predictive value and should be incorporated as one component of comprehensive evaluation. The pathophysiology of mobility-related fall risk encompasses multiple interacting systems. Age-related sarcopenia reduces lower extremity strength, diminishing the capacity to generate corrective forces in response to postural perturbations. Proprioceptive decline impairs awareness of limb position and surface characteristics, degrading the sensory feedback essential for adaptive gait. Vestibular dysfunction compromises spatial orientation and gaze stabilization during head movement. Central nervous system changes slow reaction time and motor response execution, reducing the window for successful balance recovery following a destabilizing event. Specific neurological conditions carry particularly elevated fall risk. Parkinson's disease, affecting approximately 1% of adults over age 60, produces characteristic festinating gait, postural instability, and freezing episodes that dramatically increase fall vulnerability. Stroke survivors experience hemiparetic gait patterns, asymmetric weight-bearing, and impaired protective reflexes that persist well beyond the acute recovery period. Peripheral neuropathy, which is common in diabetes and affects about 25% of older adults, produces distal sensory loss that compromises foot position awareness and surface discrimination. The third major comorbidity involves polypharmacy and fall risk-increasing drugs. Medication use represents one of the most modifiable risk factors for falls, yet it remains underaddressed in many clinical settings. The relationship between polypharmacy and falls is well established, with each additional medication conferring incremental fall risk. Meta-analytic evidence indicates that use of 4 or more medications is associated with odds ratios of 1.4 to 1.8 for falls, with the relationship strengthening as medication count increases. Beyond total medication burden, specific drug classes carry disproportionate fall risk. Systematic review and meta-analysis have identified the following high-risk categories with their associated effect sizes. Psychotropic medications demonstrate the strongest and most consistent associations with fall risk. Antidepressants, particularly selective serotonin reuptake inhibitors and tricyclic antidepressants, carry odds ratios of 1.5 to 2.3 for falls. Benzodiazepines and Z-drugs elevate fall risk by 40 to 100%, with odds ratios of 1.4 to 2 and risk particularly pronounced during initiation and dose escalation. Antipsychotic medications, both typical and atypical, are associated with odds ratios of 1.5 to 2.3 for falls, reflecting their sedative, anticholinergic, and orthostatic effects. Opioid analgesics have received increasing attention as fall risk increasing drugs, with incidence rate ratios of 1.4 to 1.7 for falls among users. The risk is compounded when opioids are combined with gabapentinoids, an increasingly common prescribing pattern. Research has demonstrated that concurrent use of opioids and gabapentin increased fall risk by 73% compared to non-use of either medication class, with an adjusted odds ratio of 1.73. Cardiovascular medications contribute to fall risk through multiple mechanisms. Loop diuretics promote orthostatic hypotension and electrolyte disturbances. Antihypertensive agents, particularly alpha blockers and centrally acting agents, may precipitate postural dizziness. Digoxin and antiarrhythmics have been associated with falls, potentially through visual disturbances or cardiac conduction effects. Anticholinergic medications warrant particular attention due to their cumulative burden effect. Systematic reviews have found that nearly 69% of older adults presenting after falls had potentially inappropriate prescribing, with a mean of over 2 inappropriate prescriptions per patient. Case control studies have demonstrated that anticholinergic burden scores of 3 or higher increased fall probability more than twofold, with an adjusted odds ratio of 2.34. The fourth major comorbidity is depression and psychological factors. Depression affects 10 to 15% of community-dwelling older adults and 25 to 50% of those in long-term care, making it among the most prevalent mental health conditions in geriatric populations. The association between depression and falls is bidirectional and substantial. Depression predicts future falls with odds ratios of 1.5 to 2, and falls, particularly injurious falls, precipitate depressive symptoms. Several mechanisms link depression to elevated fall risk. Psychomotor retardation, a cardinal feature of major depression, manifests as slowed gait, reduced reaction time, and diminished postural responses. Attentional and executive deficits commonly accompany depression in older adults, compromising the cognitive resources required for safe ambulation. Antidepressant medications, as we noted, carry intrinsic fall risk. Social withdrawal and reduced physical activity associated with depression promote deconditioning and muscle weakness. Appetite suppression may contribute to nutritional deficits and sarcopenia. Fear of falling deserves recognition as both a consequence and cause of falls. Global systematic reviews have established that fear of falling affects approximately 50% of community-dwelling older adults, with prevalence ranging from 7% to 90% across studies depending on population characteristics and measurement approach. Fear of falling is more prevalent in developing countries at 53% than developed countries at 47%, and higher among patients at 52% than community residents at 48%. The consequences of excessive fear of falling are substantial. Activity restriction, adopted as a protective strategy, paradoxically increases fall risk through deconditioning, muscle atrophy, and balance decline. Fear of falling is associated with reduced quality of life, social isolation, depressive symptoms, and loss of independence. Systematic reviews have confirmed that concern about falling independently predicts future falls, supporting its inclusion in comprehensive fall risk assessments. The fifth major comorbidity is visual impairment. Vision provides critical sensory input for postural control, hazard detection, and navigation of complex environments. Visual impairment is prevalent among older adults, affecting 15 to 30% of those aged 65 and older, and is significantly associated with fall risk, with odds ratios of 1.5 to 2.5 depending on severity and type of impairment. Age-related visual changes affecting fall risk include reduced visual acuity, contrast sensitivity decline, impaired depth perception, visual field constriction, and delayed dark adaptation. Specific pathological conditions compound these age-related changes. Cataracts produce glare sensitivity and reduced acuity. Glaucoma causes peripheral field loss, compromising hazard detection. Macular degeneration impairs central vision, essential for surface discrimination. And diabetic retinopathy produces variable and unpredictable visual deficits. The interaction between vision and other fall risk factors merits emphasis. Visual impairment compounds cognitive deficits by reducing environmental cues that might otherwise compensate for attention or memory deficits. Poor lighting, an environmental hazard, is particularly dangerous for individuals with marginal visual function. Multifocal or progressive lenses, while beneficial for many visual tasks, have been associated with increased fall risk in outdoor environments due to impaired depth perception when viewing through the lower lens segment. Now, let's discuss cumulative and multiplicative risk. A fundamental principle of fall risk assessment is that fall probability increases non-linearly with the accumulation of risk factors. Classic epidemiological studies demonstrated that the presence of no risk factors is associated with an 8% annual fall probability, rising to 27% with 2 factors, 54% with 3 factors, and 78% with 4 or more factors. More recent evidence has refined these estimates while confirming the basic multiplicative relationship. The clinical implication is that effective fall prevention must address multiple risk factors simultaneously. Single intervention approaches, such as medication review alone or exercise alone, have demonstrated limited effectiveness in most populations because they leave other contributory factors unaddressed. The most successful fall prevention programs are those that combine comprehensive assessment with tailored, multifactorial intervention addressing the individual's specific risk factor profile. Before we move on, let's briefly consider setting specific risk factor profiles. While the major risk factors for falls are consistent across settings, their relative importance and manifestation differ in ways that should guide assessment and intervention priorities. In community settings, environmental hazards such as loose rugs, inadequate lighting, and cluttered pathways interact with individual risk factors and may be particularly modifiable through occupational therapy-led home assessment. Footwear, medication self-management, and access to exercise programs represent key intervention targets. In long-term care, polypharmacy rates are extremely high, reaching 92% in some studies. Psychotropic use is endemic, affecting 40 to 70% of residents, and cognitive impairment prevalence approaches 50 to 70%. Staff training, medication optimization, and adapted exercise programs represent priority interventions. In hospital settings, acute illness, unfamiliar environments, tethering devices such as intravenous lines and urinary catheters, and delirium predominate. Delirium prevention, fall risk communication at care transitions, and environmental standardization are particularly relevant. Now let's move on to our second module, which focuses on fall risk screening, including tools and setting-specific applications. Systematic screening represents the essential first step in any comprehensive fall prevention program. The fundamental premise is straightforward. Older adults at elevated fall risk must be identified before assessment and intervention can be delivered. Yet the implementation of effective screening is more nuanced, requiring clinicians to select appropriate tools for their care setting, interpret results in clinical contexts, and determine which patients warrant further evaluation. In this module, we'll examine the evidence base for fall risk screening in older adults, with detailed attention to validated screening instruments, their diagnostic accuracy across different populations, and setting-specific application guidelines. The content draws from the 2022 World Guidelines for Falls Prevention and Management, the 2024 U.S. Preventive Services Task Force recommendations, and recent systematic reviews of screening tool performance published between 2022 and 2025. Let's begin with the rationale for universal screening. Current clinical practice guidelines recommend annual fall risk screening for all adults aged 65 years and older, regardless of whether they report previous falls. This recommendation reflects several key considerations. First, fall risk screening identifies individuals who may benefit from preventive interventions before they experience fall-related injury. The prospective nature of screening, assessing risk factors present today to predict events that may occur in the future, aligns with the preventive orientation of contemporary healthcare. Second, many older adults do not spontaneously report falls or fall risk concerns to healthcare providers. Studies consistently demonstrate that 50 to 70% of falls go unreported to clinicians, often because patients attribute falls to environmental causes like tripping on a rug, minimize their significance, or fear that disclosure will result in loss of independence. Structured screening ensures that fall risk is systematically assessed rather than dependent on patient disclosure. Third, evidence demonstrates that screening-triggered multifactorial interventions reduce fall rates among older adults at increased risk. The 2024 U.S. Preventive Services Task Force Evidence Review confirmed that exercise interventions reduce falls by 13 to 23% among community-dwelling older adults at increased risk, with multifactorial interventions providing additional benefit in selected populations. Now let's examine the CDC's STEADY initiative. The Stopping Elderly Accidents, Deaths, and Injuries Initiative, known as STEADY, was developed by the Centers for Disease Control and Prevention. It provides a comprehensive framework for fall risk identification, assessment, and intervention in clinical practice. STEADY has become the de facto standard for community-based fall risk screening in the United States and has been validated across multiple populations. The foundation of STEADY screening is the 3 key questions, which can be administered in under 1 minute. These questions are: have you fallen in the past year? Do you feel unsteady when standing or walking? And do you have concerns about falling? An affirmative response to any of these questions indicates elevated fall risk warranting further evaluation. The simplicity of this initial screen facilitates integration into routine clinical workflows. These questions can be administered by front desk staff, nursing assistants, or incorporated into patient intake questionnaires. The validity of these screening questions has been confirmed in recent research. Studies have demonstrated that the STEADY self-report measures independently predict fall risk, with each positive response conferring incremental predictive value. Additional research on the STEADY algorithm in community-dwelling older adults has confirmed its utility for identifying individuals who benefit from comprehensive assessment. For patients who screen positive on the 3 key questions, the 12-item Stay Independent questionnaire provides more detailed risk characterization. Questions address fall history, medication use, assistive device needs, balance confidence, and functional limitations. Scores of 4 or higher out of 14 possible points indicate elevated fall risk warranting multifactorial assessment. The Stay Independent questionnaire serves several clinical functions. It identifies specific risk domains requiring attention, facilitates communication with patients about their fall risk profile, and provides a baseline against which intervention effectiveness can be measured. Research demonstrates that questionnaire scores correlate with objective measures of balance and mobility, supporting their validity as indicators of underlying fall risk. Patients identified as at risk through self-report screening should undergo objective gait and balance assessment. STEADY recommends a staged approach beginning with simple observation of gait and progressing through standardized performance tests. Gait speed measurement provides a simple, rapid, and clinically meaningful assessment of mobility status. The standard protocol involves timing a patient walking at their usual pace over 4 meters, with or without an assistive device. Gait speed below 0.8 to 1 meter per second indicates impaired mobility associated with elevated fall risk, hospitalization, disability, and mortality. The clinical interpretation of gait speed requires attention to measurement conditions. Performance may vary with footwear, surface characteristics, time of day, and patient fatigue. Serial measurements are more informative than single assessments, as decline in gait speed over time predicts adverse outcomes more strongly than cross-sectional values. The Timed Up and Go test, often abbreviated as TUG, assesses functional mobility through a standardized sequence: rising from a standard armchair, walking 3 meters at usual pace, turning, returning, and sitting down. Time to complete the sequence is recorded, and values exceeding 12 seconds have traditionally been associated with elevated fall risk. Recent evidence has refined the interpretation of TUG performance. Umbrella reviews have noted inconsistent findings regarding TUG predictive validity across studies, suggesting that the traditional 12-second cutoff may require adjustment for different populations. The TUG remains clinically useful as one component of a comprehensive assessment battery, but should not be used as a sole determinant of fall risk status. The 30-second chair stand test assesses lower extremity strength and endurance. Patients are timed performing as many sit-to-stand repetitions as possible in 30 seconds. Normative values are age stratified, and fewer than 8 repetitions generally indicates impaired lower extremity function associated with fall risk. The 4-stage balance test evaluates static balance through progressively challenging stance positions: feet together, semi-tandem, tandem, and single leg stance. Inability to maintain tandem stance for 10 seconds indicates balance impairment warranting intervention. Now let's turn to hospital-based screening tools. The unique characteristics of hospitalized older adults, including acute illness, unfamiliar environments, medications, and delirium risk, necessitate screening tools designed for inpatient populations. Several validated instruments are widely used, each with distinct features and performance characteristics. The Morse Fall Scale is among the most widely implemented hospital fall risk screening tools used in acute care, rehabilitation, and long-term acute care settings worldwide. The instrument assigns points based on 6 items: history of falling, secondary diagnosis, ambulatory aid use, intravenous access or heparin lock, gait characteristics, and mental status. Total scores are categorized into low risk at 0 to 24 points, moderate risk at 25 to 44 points, and high risk at 45 or more points. These categories guide nursing intervention intensity, with higher risk patients receiving more intensive monitoring and fall prevention precautions. Recent prospective studies of fall risk assessment tools in older inpatients found that the Morse Fall Scale demonstrated the best predictive value for falls among patients aged 80 years and older, with an area under the receiver operating characteristic curve of 0.813. When combined with the Barthel Index of Functional Status, predictive accuracy improved to 0.891, suggesting that multi-instrument approaches may outperform single tools. The Stratify scale, which stands for St. Thomas Risk Assessment Tool in Falling Elderly Inpatients, was developed specifically for acute care settings. The instrument assesses 5 items: presenting fall, agitation, visual impairment, frequent toileting needs, and transfer or mobility impairment. Each item receives a binary yes or no score, with total scores of 2 or higher indicating elevated fall risk. Stratify has demonstrated variable performance across settings and populations. Systematic reviews suggest moderate sensitivity of 70 to 80%, but lower specificity of 50 to 60%, resulting in substantial numbers of false positives when applied universally. This trade-off, which is acceptable for high-sensitivity screening, means that many patients identified as high risk will not actually fall, potentially leading to intervention fatigue among nursing staff. The Johns Hopkins Fall Risk Assessment Tool, known as JHFRAT, integrates fall risk screening with intervention guidance, providing structured recommendations based on risk category. The instrument is designed for electronic health record integration and includes both a screening component for all admitted patients and a more comprehensive assessment component for patients identified as moderate or high risk. JHFRAT categorizes patients into low, moderate, and high fall risk categories, with corresponding standardized fall prevention interventions. The tool's integration with nursing care plans facilitates consistent implementation and documentation. The Hendrick 2 fall risk model differs from other hospital tools in its emphasis on intrinsic risk factors rather than situational or environmental factors. The instrument assesses confusion or disorientation, symptomatic depression, altered elimination, dizziness or vertigo, gender, use of antiepileptics, use of benzodiazepines, and rising from a seated position. The Hendrick 2 model was specifically designed to identify patients at risk for serious injury from falls, not merely fall occurrence. This focus on injury risk may improve targeting of intensive interventions toward patients most likely to benefit. Now, let's discuss long-term care screening approaches. Fall risk screening in long-term care presents unique challenges. Residents are typically at baseline elevated risk due to frailty, cognitive impairment, polypharmacy, and functional dependency. The goal of screening in this setting is less about binary risk classification, since most residents are at elevated risk, and more about identifying specific modifiable factors, tracking risk changes over time, and triggering reassessment following clinical changes. Many long-term care facilities adapt hospital-based tools like the Morse Fall Scale and Stratify for their populations. The minimum dataset, which is mandated for all Medicare and Medicaid certified nursing facilities in the United States, includes fall risk screening elements that are completed at admission and regular intervals. One specialized screening tool worth highlighting is Stop Fall, which focuses specifically on fall risk increasing drugs. The instrument provides a structured approach to medication review, identifying specific medications and drug classes associated with elevated fall risk. Research in a Swiss hospital found that 75% of high-risk patients were prescribed at least one fall risk-increasing drug at admission, with benzodiazepines, diuretics, and opioids representing the most common medication classes. Stop Fall implementation as part of routine admission screening can facilitate proactive medication review and deprescribing conversations. Let's now examine comparative diagnostic accuracy. Understanding the diagnostic accuracy of screening tools, including their sensitivity, specificity, and predictive values, is essential for appropriate clinical application. Recent systematic reviews and meta-analyses have provided increasingly refined estimates of tool performance. For performance-based measures, comparative studies of fall risk assessments in community-dwelling older adults have evaluated sensitivity, specificity, and overall accuracy across multiple instruments. Key findings include that gait speed demonstrated moderate discriminative ability, with sensitivity of 60 to 70% and specificity of 55 to 65% at the standard 0.8 meters per second threshold. Timed up and go showed variable performance, with sensitivity ranging from 55 to 85% depending on the cutoff employed and population characteristics. And the Berg Balance Scale demonstrated high sensitivity of 80 to 90%, but lower specificity of 50 to 60%, resulting in substantial false positive rates. Umbrella reviews synthesizing evidence from 31 reviews have concluded that no single performance measure predicts falls with high certainty when used in isolation. However, gait speed emerged as the most consistent predictor, supporting its inclusion in multidimensional screening protocols. For self-report measures, self-reported falls history is the single strongest predictor of future falls, with patients who report falling in the past year experiencing 2 to 3 times the fall rate of those without prior falls. The 3 key questions from study capitalize on this relationship, with affirmative responses to fall history, unsteadiness, or fear of falling each independently associated with elevated prospective fall risk. The Falls Efficacy Scale International, known as FESI, is a validated measure of concern about falling. It has demonstrated predictive validity for future falls in meta-analytic synthesis. Systematic reviews found that higher FES1 scores, indicating greater concern about falling, predicted future falls with moderate certainty, with pooled odds ratios of 1.03 to 1.08 per point increase on the full and short versions, respectively. We must also consider population-specific considerations. Screening tool performance varies across populations, and clinicians should consider population characteristics when selecting and interpreting tools. Cognitive impairment affects screening tool validity. Self-report measures may be unreliable in patients with significant memory impairment, necessitating informant-based or performance-based approaches. Systematic reviews of physical performance measures in older adults with dementia found that the short physical performance battery, Berg Balance Scale, and postural sway measures could discriminate fallers from non-fallers, while gait speed and tug predicted falls specifically in institutionalized populations. Frailty also modifies fall risk and screening tool interpretation. Pre-frail and frail older adults demonstrate higher fall rates at given screening tool scores than robust peers, potentially justifying lower thresholds for triggering intervention. Now let me outline a clinical decision framework for you. Integrating the evidence on screening tools into clinical practice requires a structured decision framework that matches screening intensity to patient characteristics and guides subsequent assessment and intervention. For the low-risk pathway, patients with negative responses to the 3 key questions, meaning no falls, no unsteadiness, and no fear of falling, are classified as low or average risk. Recommended management includes brief education about fall prevention, encouragement of regular physical activity, and rescreening at subsequent healthcare encounters at minimum annually. No multifactorial assessment or intensive intervention is required for this group, though individual clinical judgment may warrant closer attention based on other findings. For the moderate risk pathway, patients with positive responses to screening questions but without history of multiple falls or fall-related injury are classified as moderate risk. Recommended management includes gait and balance assessment using the tug, gait speed, 4-stage balance test, and 30-second chair stand. It also includes medication review for fall risk-increasing drugs, assessment of visual acuity, individualized education, and referral to a community exercise program. Patients with abnormal gait and balance testing should proceed to comprehensive multifactorial assessment. For the high-risk pathway, patients meeting any of the following criteria should proceed directly to comprehensive multifactorial assessment without further screening. History of 2 or more falls in the past year, presenting with acute fall-related injury, gait or balance abnormalities on objective testing, inability to rise from the floor independently after a fall, fall associated with loss of consciousness, or known significant frailty. These patients have demonstrated vulnerability that warrants immediate, intensive assessment and intervention. Before we move to the next module, let me touch on implementation considerations. Successful implementation of fall risk screening requires attention to workflow integration, documentation systems, and staff training. Electronic health record integration facilitates consistent implementation and enables population-level quality monitoring. EHR templates can prompt screening at appropriate intervals, flag positive results for clinician attention, and generate referrals to assessment or intervention resources. Some innovative implementations have described EHR integrated chatbot systems for connecting fall risk screening to community resources after emergency department visits. Workflow considerations are also critical. Screening effectiveness depends on practical workflow integration. Key success factors include assignment of clear responsibility for screening administration, selection of tools appropriate to setting and available time, development of clear pathways from positive screening to subsequent assessment, documentation systems that capture screening results and trigger appropriate follow-up, and quality monitoring to ensure screening completion rates. Staff training is equally important. Healthcare personnel administering screening tools require training in standardized administration procedures, result interpretation, and communication with patients. Brief training programs of 30 to 60 minutes have proven sufficient for basic screening tool administration, though more intensive training may be required for performance-based assessments. Now let's proceed to our third module on comprehensive multifactorial fall risk assessment. Screening identifies older adults at elevated fall risk, but comprehensive multifactorial assessment determines the specific factors contributing to that risk and guides individualized intervention planning. The multifactorial nature of falls, arising from the interaction of intrinsic physiological factors, medication effects, environmental hazards, and situational circumstances, necessitates systematic evaluation across multiple domains to develop effective, targeted prevention strategies. In this module, we'll examine the components of comprehensive fall risk assessment as recommended by current clinical practice guidelines, with detailed attention to assessment methods for each key domain. Content integrates recommendations from the 2022 World Guidelines for Falls Prevention and Management, USPSTF guidance, and recent evidence on assessment approaches for special populations, including those with cognitive impairment. Let me start by outlining the guideline framework for assessment. Multiple authoritative bodies have issued recommendations regarding comprehensive fall risk assessment, and their convergent guidance provides a strong foundation for clinical practice. The 2022 World Guidelines for Falls Prevention and Management represent the most comprehensive international consensus on fall prevention, developed through collaboration among 96 experts from 39 countries. The guidelines recommend stratified assessment based on risk level. Individuals identified as at increased or high risk through screening should receive comprehensive, multifactorial evaluation addressing modifiable risk factors. The 2024 U.S. Preventive Services Task Force recommendations affirm the role of comprehensive assessment in guiding intervention for community-dwelling older adults at increased fall risk. The USPSTF assigns a B recommendation, indicating moderate certainty of moderate net benefit, to exercise interventions, and a C recommendation, indicating small net benefit where the decision should be individualized, to multifactorial interventions. Both of these require adequate assessment to inform intervention selection. The European Position Paper on Polypharmacy and Fall Risk Increasing Drugs provides specific guidance on medication assessment as a component of multifactorial evaluation. The paper emphasizes that medication review should be integrated into comprehensive assessment rather than conducted in isolation, reflecting the interconnected nature of fall risk factors. Contemporary fall risk assessment frameworks converge on 7 key domains requiring systematic evaluation. Each domain represents a distinct pathophysiological contributor to fall risk, with specific assessment methods and intervention implications. Let me walk you through each of these domains in detail. The first domain is strength, gait, and balance impairment. Assessment of mobility function forms the cornerstone of fall risk evaluation, as gait and balance impairment represent the most proximate determinants of fall events. Comprehensive assessment should evaluate lower extremity strength, static and dynamic balance, and functional mobility. Lower extremity strength can be assessed through the 30-second chair stand test that I described earlier, or through manual muscle testing of key anti-gravity muscle groups, including hip extensors, knee extensors, and ankle dorsiflexors. Clinically significant weakness, defined as inability to rise from a standard height chair without using arms or fewer than 8 chair stand repetitions in 30 seconds, warrants strengthening intervention. Static balance is evaluated through progressively challenging stance positions. The 4-stage balance test, which includes feet together, semi-tandem, tandem, and single-leg stance, provides a rapid, structured approach. More detailed assessment can employ the Berg Balance Scale, a 14-item measure evaluating sitting balance, standing balance, and balance during functional tasks. The Berg Balance Scale demonstrates high sensitivity for fall risk, though specificity is more limited. Dynamic balance and gait require observation of walking and assessment of gait characteristics. The timed up and go test provides standardized functional mobility assessment. Detailed gait analysis should note cadence, stride length, base of support, arm swing, heel strike pattern, and qualitative characteristics such as shuffling, festination, or asymmetry. The identification of specific gait abnormalities guides targeted intervention. For example, festinating gait in Parkinson's disease warrants referral for disease-specific rehabilitation. Postural control assessment may include evaluation of responses to external perturbations, such as clinician-applied nudge or pull, and assessment of anticipatory postural adjustments during reaching or stepping. The Mini-BESTIST, or Balance Evaluation Systems test, provides comprehensive assessment of anticipatory postural adjustments, reactive postural control, sensory orientation, and dynamic gait. The second domain is medication use and fall risk increasing drugs. Systematic medication review is an essential component of multifactorial assessment, given the strong and modifiable association between certain medication classes and fall risk. Assessment should address total medication burden, use of specific high-risk drug classes, and medication-related symptoms. Total medication burden should be quantified with particular attention to patients taking 5 or more medications, which defines polypharmacy, or 10 or more medications, which defines excessive polypharmacy. The number of prescribers involved in the patient's care should be noted, as fragmented prescribing increases risk of inappropriate combinations and therapeutic duplication. Fall risk increasing drug identification employs validated screening tools. The stop-fall criteria provide a comprehensive list of medications associated with fall risk, organized by drug class. Key categories warranting attention include central nervous system agents such as benzodiazepines, Z-drugs, antipsychotics, antidepressants, particularly sedating tricyclics and mirtazapine, opioids, anticonvulsants, and antihistamines. Cardiovascular agents to watch for include loop diuretics, alpha blockers, vasodilators, centrally acting antihypertensives, and digoxin. Anticholinergic medications of concern include bladder antimuscarinics, first-generation antihistamines, tricyclic antidepressants, and antispasmodics. The Anticholinergic Burden Scale or Anticholinergic Cognitive Burden Scale quantifies cumulative anticholinergic load, which has dose-response relationships with both falls and cognitive impairment. Scores of 3 or higher indicate clinically significant anticholinergic burden warranting medication review. Medication-related symptoms assessment should probe for sedation, dizziness, orthostatic symptoms, visual disturbances, confusion, and urinary frequency, as all of these are medication effects that may contribute to fall risk. Timing relationships between medication initiation or dose changes and fall events should be explored. The third domain is postural hypotension. Orthostatic hypotension, defined as a sustained reduction in systolic blood pressure of at least 20 millimeters of mercury or diastolic blood pressure of at least 10 millimeters of mercury within 3 minutes of standing, affects 20 to 30% of community-dwelling older adults and is significantly associated with falls, syncope, and mortality. The assessment protocol requires blood pressure measurement in the supine position after 5 minutes of rest, and then at 1 and 3 minutes after standing. The patient should be asked about symptoms such as lightheadedness, visual dimming, and weakness during standing, as symptomatic orthostatic hypotension carries greater clinical significance than asymptomatic findings. Contributing factors to explore include volume depletion from inadequate fluid intake or diuretic use, antihypertensive medications, particularly alpha blockers and vasodilators, autonomic dysfunction, which is common in diabetes and Parkinson's disease, and prolonged bed rest. Postprandial hypotension, meaning blood pressure reduction following meals, may be relevant in patients who report falls occurring after eating. The fourth domain covers foot and footwear problems. Foot health and appropriate footwear are frequently overlooked fall risk factors with significant modifiability. Assessment should encompass foot structure, skin and nail integrity, sensation, and footwear characteristics. Foot examination should evaluate structural deformities such as bunions, hammer toes, and Charcot foot. It should also assess skin integrity, including calluses, ulcers, and fissures, as well as nail abnormalities like onychogryphosis and fungal infection, and edema. Each of these conditions can affect gait biomechanics and increase fall risk. Sensory assessment with monofilament testing identifies peripheral neuropathy affecting protective sensation. Loss of protective sensation at the plantar surface, meaning inability to detect 10-gram monofilament, indicates neuropathy warranting appropriate footwear, regular foot inspection, and potentially podiatry referral. Footwear assessment examines currently worn shoes and recommends appropriate modifications. Optimal footwear for fall prevention features low heel height of 2.5 centimeters or less, firm heel collar, non-slip sole, and adequate fixation through laces, Velcro, or strap, rather than slip-on style. Worn shoes with degraded soles or unstable heel counters should be replaced. House shoes, bedroom slippers, and walking barefoot or in stocking feet increase fall risk and should be discouraged. The fifth domain is vision impairment. Given the critical role of vision in hazard detection, depth perception, and postural control, visual assessment is an essential component of fall risk evaluation. Visual acuity testing with a Snellen chart or equivalent identifies patients requiring optometry or ophthalmology referral. Acuity worse than 20/40 warrants correction, and acuity worse than 20/70 constitutes low vision requiring specialized assessment and adaptive strategies. Contrast sensitivity assessment, when available, provides additional information about functional vision relevant to fall risk. Contrast sensitivity decline, which is common in cataracts and glaucoma, impairs detection of surface changes and step edges even when Snellen acuity is relatively preserved. Eye disease screening should identify cataracts, which are the most common correctable cause of visual impairment, glaucoma, which requires peripheral field assessment, macular degeneration, which affects central vision, and diabetic retinopathy, which is common in diabetes. Referral to ophthalmology is indicated for suspected pathology. Multifocal lens use warrants specific inquiry, as progressive and bifocal lenses have been associated with increased fall risk in outdoor environments due to distorted depth perception when viewing through lower lens segments. Recommendation of single lens distance glasses for outdoor walking may be appropriate for some patients. The sixth domain is osteoporosis and vitamin D deficiency. While osteoporosis and vitamin D deficiency do not directly cause falls, they substantially influence fall consequences and represent modifiable factors in comprehensive fall prevention. Osteoporosis assessment determines fracture risk if a fall occurs. Dual energy X-ray absorptiometry scanning, known as DEXA, provides bone mineral density measurement at hip and spine, with T-scores of -2.5 or lower defining osteoporosis. The FRAX calculator integrates bone density with clinical risk factors to estimate 10-year fracture probability, guiding treatment decisions. Vitamin D status assessment through serum 25-hydroxyvitamin D measurement identifies deficiency, typically defined as less than 20 nanograms per milliliter or less than 50 nanomoles per liter, and insufficiency, defined as less than 30 nanograms per milliliter or less than 75 nanomoles per liter. Meta-analytic evidence supports vitamin D supplementation for fall prevention specifically in individuals with deficiency. Network meta-analyses have demonstrated that vitamin D at doses of 800 to 1,000 international units daily reduced fall risk with a relative risk of 0.85 compared with placebo, with benefit concentrated among those with baseline deficiency, showing a relative risk of 0.69 for deficiency at or below 50 nanomoles per liter. Fall injury risk stratification integrates osteoporosis status, anticoagulation use, frailty, and prior fragility fractures to identify patients at highest risk for serious fall-related injury. These individuals warrant prioritization for intensive fall prevention intervention. The seventh and final domain is home safety and environmental hazards. Environmental factors contribute to approximately 1/3 of falls among community-dwelling older adults, making home safety assessment a critical component of comprehensive evaluation. Structured home safety assessment, ideally conducted by an occupational therapist through home visit, evaluates multiple areas. For flooring hazards, look for loose rugs, slippery surfaces, uneven thresholds, and cluttered pathways. For lighting, assess for inadequate illumination, absence of nightlights, and glare from uncovered windows. For stairs, check for missing or loose handrails, inconsistent step heights, and poor visibility of step edges. In the bathroom, look for absence of grab bars, slippery tub or shower, and toilet height inappropriate for transfers. In the bedroom, evaluate bed height, nightstand accessibility, and the pathway to the bathroom. In the kitchen, assess storage accessibility, including high shelves and low cabinets, and floor condition. For exterior areas, check step condition, pathway surfaces, and lighting. Cochrane reviews have demonstrated that home fall hazard interventions reduce fall rates by 26% overall, with a rate ratio of 0.74. When targeted to individuals at higher baseline fall risk, these interventions reduced fall rates by 38%, with a rate ratio of 0.62. This evidence strongly supports incorporation of environmental assessment into comprehensive evaluation. Assistive device assessment evaluates current device use, appropriateness, and correct utilization. Canes, walkers, and other mobility aids require proper fitting and training. Improperly used devices can increase rather than decrease fall risk. Now let me explain how to integrate all of these assessment components. Effective multifactorial assessment requires integration of domain-specific findings into a coherent understanding of the individual patient's fall risk profile. This integration should address several key areas. First, risk factor prioritization. Which factors are most modifiable? Which contribute most to this patient's risk? Resource-limited settings may necessitate focusing on highest yield intervention targets. Second, interaction effects. How do this patient's risk factors compound one another? For example, visual impairment combined with peripheral neuropathy creates greater risk than either factor alone. Third, patient preferences. Which interventions is this patient willing and able to implement? Shared decision-making should incorporate patient priorities and values. Fourth, setting-specific considerations. Community-dwelling patients may benefit from home assessment. Long-term care residents require attention to staffing and environmental standardization. Hospitalized patients need delirium prevention and safe mobility plans. We must also address special considerations for cognitive impairment. Assessment of older adults with cognitive impairment requires adaptation of standard approaches to accommodate limited self-report reliability, attention deficits, and comprehension difficulties. History acquisition should incorporate informant perspectives from caregivers and family, as patients with significant cognitive impairment may not accurately recall fall events or associated symptoms. Direct questioning should employ simple, concrete language and closed-ended questions when possible. Performance testing may require modification. Instructions should be simplified and repeated. Demonstration may supplement verbal directions. Additional time should be allowed for task completion. Despite these accommodations, some standard assessment tools may not be valid in patients with moderate to severe dementia. Delirium assessment is particularly important, as delirium is both a consequence of falls, indicating possible head injury or other acute condition, and a risk factor for future falls. The confusion assessment method, or CAM, or equivalent screening, should be incorporated into assessment of cognitively impaired patients who present after falls. Caregiver assessment evaluates the support available to implement fall prevention strategies. Cognitively impaired patients typically require caregiver involvement for medication management, exercise program adherence, and environmental modification implementation. Assessment findings should inform risk stratification, which in turn guides intervention intensity and setting. Increased risk patients, meaning those with positive screening and one or two modifiable risk factors identified, typically benefit from targeted single-factor or limited multifactorial intervention, such as exercise referral, medication review, or environmental assessment depending on identified needs. High-risk patients, meaning those with multiple modifiable risk factors, prior falls with injury, significant gait and balance impairment or frailty, warrant comprehensive multifactorial intervention addressing all identified risk domains. This population demonstrates the greatest absolute benefit from intensive fall prevention programs. Very high-risk patients, including those with recurrent falls despite intervention, severe mobility impairment, or advanced dementia, may require a palliative approach focused on injury mitigation rather than fall prevention per se. This might include hip protectors, environmental padding, and supervised mobility only. Documentation and communication are critical final steps. Comprehensive fall risk assessment generates substantial information requiring systematic documentation and communication. Documentation should capture assessment findings in each domain, identified modifiable risk factors, recommended interventions, and patient and caregiver involvement in care planning. Standardized templates facilitate consistent, complete documentation. Communication between the assessment team and primary care providers ensures continuity and coordination. Assessment findings and recommendations should be transmitted to prescribers for medication review implementation, to referring providers for care coordination, and to relevant specialists such as ophthalmology, cardiology, or neurology as indicated. Reassessment planning establishes appropriate follow-up intervals based on risk level and intervention implementation. High-risk patients typically warrant reassessment at 3 to 6 month intervals, while lower-risk patients may be appropriate for annual reassessment. Now, let's move to our fourth module, which covers evidence-based interventions including exercise, environmental modifications, and multifactorial programs. The translation of fall risk assessment into effective intervention represents the critical action step in fall prevention. Decades of research have established a robust evidence base demonstrating that targeted interventions can substantially reduce fall rates and fall-related injuries among older adults. However, the effectiveness of interventions varies considerably based on population characteristics, intervention components, delivery methods, and implementation fidelity. In this module, we'll examine the evidence for exercise interventions, environmental modifications, and multifactorial programs, which represent the three pillars of contemporary fall prevention. Content draws from major systematic reviews and meta-analyses published between 2022 and 2025, including the evidence report supporting the 2024 USPSTF recommendations and Cochrane systematic reviews of interventions across care settings. Let's start with exercise interventions, which are truly the foundation of fall prevention. Exercise represents the single most effective and most extensively studied intervention for fall prevention in older adults. The 2024 USPSTF assigns exercise interventions a B recommendation, indicating moderate certainty of moderate net benefit for community-dwelling older adults at increased fall risk. This recommendation reflects consistent evidence across multiple systematic reviews and meta-analyses, demonstrating fall rate reductions of 13 to 24% with appropriately designed exercise programs. The evidence for exercise effectiveness is compelling. Systematic reviews supporting the USPSTF recommendations synthesized evidence from 78 randomized controlled trials of fall prevention interventions. Exercise interventions demonstrated consistent benefit. For fall rate reduction, the pooled rate ratio was 0.85, representing a 15% reduction in the rate of falls. For risk of falling, the pooled risk ratio was 0.89, representing an 11% reduction in the proportion of participants experiencing at least one fall. For fall-related injuries, there was a modest but significant reduction in injurious falls. Comprehensive systematic reviews have extended these findings, examining 283 randomized trials of community fall prevention interventions. These analyses confirmed exercise effectiveness and provided insight into patient values and preferences, finding that most older adults view exercise-based fall prevention favorably when presented with evidence of effectiveness. However, not all exercise programs are equally effective for fall prevention. Meta-analytic evidence has identified characteristics of programs demonstrating greatest benefit. Regarding exercise type, programs incorporating balance training, functional exercises, and strength training demonstrate the strongest effects. The combination of these modalities rather than any single component appears critical. Aerobic exercise alone, such as walking programs, has not shown consistent fall reduction benefit, though it provides other health benefits. Regarding total dose, programs delivering a minimum of 50 hours of exercise over the intervention period demonstrate more consistent benefit than lower dose programs. This threshold can be achieved through various frequency and duration combinations, but represents approximately 3 hours per week over 4 months or equivalent. Regarding duration and frequency, most effective programs involve exercise sessions 2 to 3 times per week, continuing for at least 12 weeks. Evidence suggests ongoing exercise is necessary to maintain benefit. Fall prevention gains diminish after exercise cessation. Regarding progression, programs should incorporate progressive challenge, meaning increasing difficulty of balance tasks, resistance, or duration over time to continue driving physiological adaptation. Let me now describe some specific exercise modalities that have accumulated substantial evidence. Tai Chi has accumulated substantial evidence supporting effectiveness for fall prevention. Systematic reviews and meta-analyses of randomized controlled trials have found that Tai Chi significantly reduced fall rates and improved balance measures compared with control conditions. The practice combines balance challenge, lower extremity strengthening, weight shifting, and mindful movement in a format that many older adults find enjoyable and sustainable. Dance-based interventions have emerged as an alternative exercise approach with promising evidence. Systematic reviews have demonstrated that dance interventions significantly reduce fall rates compared with control conditions, with the social and enjoyable nature of dance potentially supporting superior adherence compared with traditional exercise programs. Sensoromotor and proprioceptive training programs specifically targeting the balance system have shown effectiveness in meta-analysis. Systematic reviews have found that programs emphasizing sensory integration, perturbation training, and proprioceptive challenge improve balance outcomes relevant to fall prevention. Power training, which is resistance exercise emphasizing movement velocity in addition to load, has demonstrated particular benefit for fall-related functional outcomes. Systematic reviews have found that power training improved chair rise performance, gait speed, and other fall-relevant measures, with effects comparable or superior to traditional strength training. For populations with cognitive impairment, fall prevention exercise presents unique challenges and opportunities. The PRAISE trial, which stands for Promoting Activity, Independence, and Stability in Early Dementia, tested an intensive, individually tailored exercise and functional training program in individuals with mild cognitive impairment or early dementia. Despite high intervention intensity of more than 50 hours over 12 months, The trial found no significant benefit for activities of daily living, physical activity, quality of life, or falls compared with usual care. In contrast, the Vivifrail multi-component exercise program demonstrated significant benefits in a population with mild cognitive impairment and dementia. Multi-center randomized trials found that the Vivifrail program improved short physical performance battery scores by 1.4 points at 3 months, with additional benefits in cognition, muscle function, and mood. The program emphasizes individually tailored progressive exercise with caregiver involvement. These divergent findings suggest that exercise program design matters substantially for cognitively impaired populations. Programs that are highly individualized, involve caregivers, and focus on functional tasks may be more effective than standardized approaches. Systematic reviews of physical activity interventions for frail and pre-frail older adults have found that exercise programs effectively reduce fear of falling in this vulnerable population, addressing both physical and psychological fall risk factors. Now, let's turn to environmental modifications. Environmental hazards contribute to approximately 30 to 50% of falls among community-dwelling older adults, making environmental assessment and modification a logical intervention target. However, the evidence for environmental interventions is more nuanced than might be expected, with effectiveness strongly dependent on population targeting. Cochrane reviews provide the most comprehensive synthesis of environmental intervention evidence. Key findings include that home fall hazard reduction interventions probably reduce the overall rate of falls by 26%, with a rate ratio of 0.74. This is moderate certainty evidence from 12 studies with over 5,000 participants. Importantly, interventions were substantially more effective when targeted to individuals at higher baseline fall risk. Among high-risk participants, meaning those with prior falls, recent hospitalization, or support needs for daily activities, home hazard interventions reduced fall rates by 38%, with a rate ratio of 0.62. This is high certainty evidence. When offered to unselected populations not at elevated baseline risk, home hazard interventions showed no evidence of effect, with a rate ratio of 1.05. This is also high certainty evidence. This pattern has critical implications for clinical practice. Environmental modification resources should be targeted to individuals with documented elevated fall risk, not offered as universal intervention. The most effective environmental intervention programs involve comprehensive home assessment by trained occupational therapists, followed by individualized recommendations and facilitation of modifications. Implementation studies have demonstrated that occupational therapist-led environmental assessment can be successfully embedded in routine clinical practice with sustained penetration and fidelity. Key components of effective occupational therapy-led environmental intervention include systematic hazard identification using standardized assessment tools, collaborative problem-solving with patient and family to prioritize modifications, facilitation of modification implementation including contractor referrals and equipment procurement, follow-up assessment to verify modification completion and proper use, and behavioral strategies teaching safe task performance in addition to physical modifications. The COMPASS trial, which stands for Community Participation Transition After Stroke, examined a home-based occupational therapist-led intervention combining environmental modification and self-management training for stroke survivors transitioning from inpatient rehabilitation. The intervention significantly reduced skilled nursing facility admission and mortality compared with stroke education control, demonstrating the value of environmental and self-management intervention during care transitions. Evidence supports effectiveness of specific modifications, including grab bar installation in bathrooms at tub and shower entry and toilet area, non-slip surfaces in tub and shower, improved lighting in hallways, stairs, and nighttime pathways, handrail installation on all stairs with both sides for lengthy staircases, removal or securing of loose rugs, reduction of clutter in pathways, stair edge contrast strips to improve visibility, and raised toilet seats or toilet frames when indicated. Vision correction represents a form of internal environmental modification, optimizing the sensory interface between the individual and their environment. However, evidence for vision interventions in fall prevention is less consistent than might be expected. Cochrane reviews found that vision improvement interventions, primarily first-eye cataract surgery, may make little or no difference to fall rates, with a rate ratio of 1.12. This counterintuitive finding may reflect that visual improvement changes the individual's sensoromotor baseline, requiring adaptation that may temporarily increase fall risk. Practical recommendations based on available evidence include referral for cataract surgery when indicated with awareness of a temporary adaptation period, annual eye examinations with appropriate refractive correction, consideration of single-lens distance glasses for outdoor walking and multifocal lens users, and adequate lighting in the home environment, particularly on stairs and pathways. Now, let's discuss multifactorial intervention programs. Multifactorial interventions, which are programs that assess individual risk factor profiles and deliver tailored interventions addressing multiple identified factors, represent the most comprehensive approach to fall prevention. The logic is intuitive. Since falls result from multiple interacting factors, addressing multiple factors should produce greater benefit than single factor approaches. The evidence base for multifactorial interventions is substantial but somewhat inconsistent. The 2024 USPSTF evidence review found that multifactorial interventions reduce fall rates by approximately 21%, with a pooled rate ratio of 0.79, but with considerable heterogeneity across studies. Based on this evidence, the USPSTF assigned a C recommendation indicating small net benefit and recommending individualized decision-making about offering multifactorial intervention. The inconsistency in multifactorial intervention evidence has prompted investigation into characteristics distinguishing effective from ineffective programs. Systematic review evidence has identified features associated with more effective multifactorial interventions. Assessment comprehensiveness is important. Programs with systematic, comprehensive assessment across multiple risk domains demonstrate better outcomes than those with limited assessment scope. Intervention tailoring matters. True tailoring, meaning selecting and modifying interventions based on individual assessment findings, outperforms standardized one-size-fits-all packages labeled as multifactorial. Exercise inclusion is key. Multifactorial programs that include exercise as a core component demonstrate more consistent benefit than those without structured exercise. Implementation intensity plays a role. Programs with more intensive delivery, closer follow-up, and higher dose of intervention contact demonstrate better outcomes. And healthcare provider involvement helps. Programs engaging prescribers in medication review and primary care providers in care coordination show better implementation of medication-related recommendations. Setting-specific evidence shows some variation. In community settings, multifactorial interventions demonstrate modest but significant benefit for community-dwelling older adults at increased fall risk, particularly when including exercise and comprehensive assessment components. In hospital settings, systematic reviews found that multifactorial interventions reduce falls in hospitals with a pooled rate ratio of 0.77 compared with usual care. Effective hospital-based programs typically include fall risk screening, bed and chair sensors for high-risk patients, patient education, environmental standardization, and staff training. In long-term care settings, Cochrane reviews examined interventions for fall prevention in care facilities. Multifactorial interventions demonstrated benefit in long-term care with rate ratios of 0.61 to 0.85 depending on intervention characteristics, with greatest effectiveness seen in programs featuring tailored intervention delivery and sustained staff engagement. Based on systematic review evidence, comprehensive multifactorial programs should incorporate systematic risk assessment across all major domains. Risk factor-specific interventions tailored to assessment findings, exercise program addressing balance, strength, and functional mobility, medication review with prescriber involvement for deprescribing recommendations, environmental assessment with modification recommendations, vision assessment with referral as indicated, education on fall risk factors and prevention strategies, care coordination ensuring implementation of recommendations across setting. Network meta-analyses have compared effectiveness across intervention types and combinations, providing insight into optimal intervention selection. Combined exercise with vision assessment and environmental modification demonstrated particularly strong effects in network meta-analysis, with odds ratios for injurious falls reaching 0.30 compared with usual care, representing a 70% reduction in serious fall-related injuries. This finding supports comprehensive intervention approaches for high-risk individuals. The World Guidelines Synthesis recommends that all older adults receive physical activity promotion and environmental safety awareness. Increased risk individuals should receive exercise intervention, targeted environmental assessment, and medication review. And high-risk individuals should receive comprehensive multifactorial intervention addressing all identified modifiable risk factors. The translation of intervention evidence into clinical practice requires attention to implementation factors that determine real-world effectiveness. Exercise intervention effectiveness depends fundamentally on adherence. Studies demonstrate that fall prevention benefits are proportional to exercise dose achieved, and benefits diminish when exercise is discontinued. Strategies supporting adherence include group-based programs offering social support, programs perceived as enjoyable such as Tai Chi or dance, individualized progression matching patient capacity, home-based options for those unable to attend group programs, and technology-supported monitoring and reminders. Given limited healthcare resources, prioritization is necessary. Evidence supports targeting intensive intervention to high-risk individuals, those with multiple risk factors, prior falls, or significant gait and balance impairment, where absolute benefit is greatest. Lower risk individuals may receive less intensive intervention focused on exercise promotion and general fall risk education. Effective multifactorial intervention requires coordination across multiple providers and settings. Clear communication pathways, electronic health record integration, and designated care coordination roles facilitate implementation of assessment recommendations. Now let's proceed to our fifth module on medication review and pharmacological considerations in fall prevention. Medications represent one of the most modifiable fall risk factors, yet medication-related fall risk frequently goes unaddressed in clinical practice. The complex interplay between polypharmacy, specific high-risk drug classes, and individual patient vulnerabilities creates a landscape where thoughtful medication review can meaningfully reduce fall risk, but where simplistic approaches, such as universal deprescribing, may fail or cause harm. In this module, we'll examine the evidence connecting medication use to fall risk, provide detailed guidance on identifying fall risk-increasing drugs, and address the nuanced clinical considerations surrounding medication review and deprescribing as fall prevention strategies. Content integrates evidence from systematic reviews published between 2022 and 2025, including analyses of deprescribing interventions and high-risk medication associations. Let's start by examining polypharmacy and fall risk in more detail. Polypharmacy, conventionally defined as concurrent use of 5 or more medications, is endemic among older adults. Prevalence estimates suggest that 30 to 40% of community-dwelling older adults and 80 to 90% of long-term care residents meet this threshold, with excessive polypharmacy of 10 or more medications affecting 10 to 20% of community-dwelling elders and 40 to 60% of nursing home residents. The relationship between medication count and fall risk follows a dose-response pattern. Each additional medication confers incremental risk, with odds ratios of 1.1 to 1.2 per medication in most studies. At the threshold of 5 or more medications, the cumulative risk becomes clinically significant, with odds ratios of 1.4 to 1.8 for falls. Beyond 10 medications, fall risk escalates further. Several mechanisms link polypharmacy to falls beyond the simple accumulation of individual drug effects. Drug-drug interactions may potentiate sedative, hypotensive, or anticholinergic effects. Medication regimen complexity increases the likelihood of dosing errors. Multiple prescribers may not recognize cumulative risks from medications in different classes, and the burden of managing complex regimens may itself contribute to confusion and adherence problems. Not all medications carry equivalent fall risk. Systematic reviews have identified specific drug classes with strong, consistent associations with falls. Understanding these high-risk categories enables targeted medication review. Psychotropic medications demonstrate the strongest and most consistent associations with fall risk, reflecting their combined effects on central nervous system function, postural reflexes, and alertness. Benzodiazepines and Z-drugs such as zolpidem, zopiclone, and zaleplon increase fall risk by 40 to 100%, with odds ratios of 1.4 to 2 across studies. Risk is particularly elevated during initiation and dose escalation. The mechanism involves sedation, impaired reaction time, anterograde amnesia, muscle relaxation, and morning after residual effects. Clinical reviews have examined the therapeutic dilemma posed by these medications. They remain widely prescribed for insomnia and anxiety despite clear fall risk, because discontinuation may precipitate rebound symptoms, withdrawal, or inadequately treated underlying conditions. Antidepressants carry odds ratios of 1.5 to 2.3 for falls, with risk present across medication subclasses. Selective serotonin reuptake inhibitors, despite being considered safer than older agents, are associated with fall risk through hyponatremia, orthostatic hypotension, and sedation. Tricyclic antidepressants carry additional anticholinergic and cardiac conduction risks. Serotonin norepinephrine reuptake inhibitors and mirtazapine also demonstrate significant fall risk associations. Antipsychotics, both typical and atypical, increase fall risk by 50 to 130%. With odds ratios of 1.5 to 2.3. Mechanisms include sedation, orthostatic hypotension, extrapyramidal effects, and anticholinergic burden. The risk applies even at low doses used for non-psychiatric indications, such as low-dose quetiapine for insomnia. Studies of medication effects in dementia inpatients have found that higher antipsychotic doses in the 24 hours preceding falls were associated with fall events, suggesting acute dose-response relationships. Opioid use has increased substantially in older adult populations and is associated with fall risk elevations of 40 to 70%, with incidence rate ratios of 1.4 to 1.7. Mechanisms include sedation, dizziness, cognitive impairment, and gait instability. Analyses have demonstrated that concurrent use of opioids and gabapentinoids, which is a common prescribing pattern for chronic pain, increases fall risk by 73% compared with non-use of either medication class, with an adjusted odds ratio of 1.73. This highlights the danger of polypharmacy within pain management regimens. Several cardiovascular medication classes contribute to fall risk, primarily through hypotensive and orthostatic effects. Loop diuretics promote volume depletion, electrolyte disturbances, particularly hypokalemia and hyponatremia, and orthostatic hypotension. Alpha blockers, used for hypertension and benign prostatic hyperplasia, carry particularly high orthostatic risk. Centrally acting antihypertensives such as clonidine and methyldopa produce sedation and orthostatic effects. Vasodilators and nitrates may precipitate postural symptoms. The evidence for some cardiovascular medications is more nuanced. Beta blockers, ACE inhibitors, and angiotensin receptor blockers show inconsistent associations with falls, suggesting that class-wide recommendations may be inappropriate. Individual patient factors, including baseline blood pressure, orthostatic symptoms, and heart rate response, should guide decisions about these medications. Medications with anticholinergic properties contribute to fall risk through multiple mechanisms: sedation, cognitive impairment, blurred vision, urinary retention prompting nocturia after discontinuation, and constipation leading to straining and orthostatic stress. The concept of anticholinergic burden recognizes that cumulative anticholinergic load from multiple medications exceeds the risk of individual agents. Case control studies have demonstrated that anticholinergic burden scores of 3 or higher increased fall probability more than twofold, with an adjusted odds ratio of 2.34. The same studies found that 92% of hospitalized older adults who fell had polypharmacy, and 88% had received psychotropic medications. Medications with significant anticholinergic properties include first-generation antihistamines such as diphenhydramine and chlorpheniramine, bladder antimuscarinics such as oxybutynin and tolterodine, tricyclic antidepressants such as amitriptyline and nortriptyline, antipsychotics such as chlorpromazine, clozapine, and olanzapine, muscle relaxants such as cyclobenzaprine and orphenadrine, and gastrointestinal antispasmodics such as dicyclamine and hyoscyamine. Additional medication classes with documented fall risk associations include anticonvulsants, which cause sedation, ataxia, and cognitive effects, skeletal muscle relaxants, which cause sedation, weakness, and dizziness, anti-Parkinson agents, which cause hypotension, psychosis, and dyskinesias, insulin and sulfonylureas, which can cause hypoglycemia-related falls, and digoxin, which can cause visual disturbances, nausea, and arrhythmias at toxic levels. Validated instruments facilitate systematic identification of fall risk-increasing drugs during medication review. STOP Fall, which stands for Screening Tool of Older Persons' Prescriptions in Older Adults with High Fall Risk, provides comprehensive criteria for identifying fall risk-increasing drugs. Studies have found that 75% of high-risk patients were prescribed at least one fall risk-increasing drug at admission, with benzodiazepines, diuretics, and opioids representing the most commonly identified medication classes. Stop fall criteria organize fall risk-increasing drugs by pharmacological class and specify both the implicated medications and recommended actions such as deprescribe, dose reduce, or monitor more closely. The American Geriatric Society Beers criteria, updated in 2023, identify potentially inappropriate medications for older adults, including many fall risk-increasing drugs. While not specifically focused on falls, the Beers criteria provide evidence-graded recommendations regarding medications to avoid or use with caution in older adults. Multiple tools quantify anticholinergic medication burden, including the Anticholinergic Cognitive Burden Scale, Anticholinergic Drug Scale, and Anticholinergic Risk Scale. These instruments assign point values to medications based on anticholinergic potency, with summed scores indicating cumulative burden. Scores of 3 or higher warrant attention for potential deprescribing. Given the strong associations between specific medication classes and fall risk, medication review and deprescribing represent logical intervention targets. However, the evidence for medication-focused interventions as standalone fall prevention strategies is surprisingly limited. Systematic review and meta-analysis examining medication reviews and deprescribing as single interventions in fall prevention found no significant effect on fall rates, with a rate ratio of 0.98 when medication interventions were implemented without other fall prevention components. This finding does not indicate that medication review is ineffective. Rather, it suggests that medication review as an isolated intervention, without addressing other fall risk factors, produces limited benefit. The World Guidelines recommend medication review as one component of multifactorial intervention, not as a standalone strategy. More recent evidence has illuminated characteristics of medication review programs that demonstrate effectiveness. Intervention component analyses of successful medication review and deprescribing programs in residential aged care have identified key features: integration with comprehensive fall prevention rather than isolated implementation, prescriber engagement ensuring deprescribing recommendations are acted upon, pharmacist involvement in medication review and patient counseling, follow-up monitoring to assess for withdrawal effects or symptom recurrence, and patient and family education supporting understanding and adherence to changes. Systematic reviews of emergency department programs supporting medication safety have found that emergency department-initiated medication review can reduce 30-day emergency department revisits and falls when structured protocols guide intervention. The emergency department represents a teachable moment for medication intervention after fall-related visits. Initiatives to deprescribe high-risk drugs for older adults presenting to the emergency department after falls have targeted psychotropic medications, opioids, and other high-risk agents, with pharmacist-led medication review and deprescribing recommendations communicated to primary care providers. Such programs address a recognized gap. Patients who present to the emergency department after falls often have medications contributing to their fall risk, but emergency department visits typically do not result in medication optimization. Medication management in cognitively impaired older adults requires particular attention. These individuals are disproportionately exposed to psychotropic medications, particularly antipsychotics and benzodiazepines, and anticholinergic agents, yet may be unable to report medication side effects or participate in shared decision-making. Narrative reviews on dementia prevention and treatment have emphasized that anticholinergics and psychotropics increase both fall risk and cognitive decline in this population, creating compelling rationale for deprescribing. Cochrane reviews have examined anticholinergic deprescribing interventions for cognitive outcomes, but found insufficient evidence to draw conclusions about effectiveness, highlighting the need for further research. When implementing medication changes for fall prevention, clinicians should consider several practical factors. For prioritization, not all fall risk increasing drugs are equally modifiable. Prioritize medications with the strongest fall risk associations such as psychotropics and opioids, unclear or questionable indications, opportunities for non-pharmacological alternatives, and patient willingness to discontinue. For tapering, many high-risk medications including benzodiazepines, antidepressants, and opioids require gradual dose reduction to avoid withdrawal syndromes. Abrupt discontinuation is rarely appropriate. For monitoring, after dose reduction or discontinuation, monitor for return of symptoms the medication was treating, withdrawal effects, changes in other medications when drug interactions are eliminated, and impact on fall risk and function. For communication, ensure all prescribers are aware of medication changes and rationale. Fragmented communication across prescribers undermines deprescribing efforts. Vitamin D supplementation warrants specific attention as a pharmacological fall prevention intervention with evidence supporting targeted use. Network meta-analyses have synthesized evidence on vitamin D supplementation for fall prevention with key findings. Vitamin D at 800 to 1,000 international units daily reduced fall risk with a relative risk of 0.85 compared with placebo. Daily dosing demonstrated effectiveness with a relative risk of 0.78, while intermittent high-dose supplementation did not show benefit. Benefit was concentrated among individuals with baseline deficiency at or below 50 nanomoles per liter, with a relative risk of 0.69 for this subgroup. Combined vitamin D and calcium supplementation did not provide additional benefit over vitamin D alone. Additional meta-analyses have confirmed that vitamin D supplementation at doses of 700 to 2,000 international units daily is associated with reduced fall risk, though the absolute risk difference is modest at approximately 6 percentage points. Based on available evidence, vitamin D supplementation for fall prevention should target individuals with deficiency, as testing serum 25-hydroxyvitamin D identifies those most likely to benefit. Appropriate dosing is 800 to 2,000 international units daily, as higher doses have not shown additional benefit and may cause harm. High-dose intermittent regimens should be avoided, as annual megadoses have been associated with increased fall risk. And vitamin D supplementation should be integrated with comprehensive assessment, complementing rather than replacing multifactorial fall prevention. Special considerations apply in different settings. In community settings, medication review typically occurs during primary care visits or specialty consultations. Challenges include fragmented prescribing across multiple providers, patient reluctance to discontinue medications, and limited time for comprehensive review. Pharmacist involvement through medication therapy management programs can enhance review quality. In long-term care, nursing home residents experience extreme polypharmacy prevalence and high psychotropic use rates. Consultant pharmacist reviews are required by regulation but may not consistently address fall risk considerations. Successful programs in long-term care feature close collaboration between pharmacists, prescribers, and nursing staff, standardized deprescribing protocols, and ongoing monitoring systems. In hospital settings, hospitalization provides opportunity for medication review, but also creates risks. New medications may be added for acute conditions, home medications may be held or changed, and communication gaps at discharge may perpetuate inappropriate prescribing. Medication reconciliation at admission and discharge represents a critical safety practice that should incorporate fall risk considerations. Now let's proceed to our sixth module on implementation strategies, adherence, and technology integration. The evidence base for fall prevention interventions is robust, yet implementation in clinical practice remains inconsistent. The gap between what we know works and what actually happens in healthcare settings represents one of the most significant challenges in fall prevention. Closing this implementation gap requires attention to workflow integration, organizational factors, patient adherence, and emerging technologies that may enhance intervention delivery and monitoring. In this module, we'll examine strategies for implementing fall prevention programs across care settings, address barriers and facilitators of patient adherence, and explore the role of technology in contemporary fall prevention practice. Content draws from implementation science literature, quality improvement studies, and technology assessments published between 2022 and 2025. Successful implementation of fall prevention programs requires systematic attention to organizational context, clinical workflows, and stakeholder engagement. Implementation science offers frameworks for understanding and addressing factors that determine whether evidence-based interventions achieve their intended impact in real-world settings. Several key implementation considerations deserve attention. Leadership support is essential. Organizational leaders must prioritize fall prevention as a quality and safety objective, allocating resources, establishing accountability, and communicating the importance of systematic fall prevention to all staff levels. Workflow integration is critical. Fall risk screening and assessment must fit within existing clinical workflows rather than requiring substantial additional time or parallel processes. The most sustainable programs integrate fall prevention activities into routine care rather than creating separate fall prevention programs. Staff training is necessary. All personnel who interact with older adults, including front desk staff, nursing assistants, therapists, nurses, and physicians, require education on fall prevention appropriate to their roles. Training should address fall risk factors, screening administration, assessment components, intervention options, and documentation requirements. Documentation systems matter. Electronic health record templates and clinical decision support tools facilitate consistent documentation and guide appropriate follow-up. Systems should capture screening results, assessment findings, intervention plans, and outcomes. Quality monitoring sustains improvement. Ongoing measurement of process metrics such as screening rates, assessment completion, and intervention referral, as well as outcome metrics such as fall rates and fall-related injuries, enables identification of implementation gaps and tracking of improvement over time. The CDC Study Initiative provides comprehensive implementation resources for healthcare organizations seeking to establish or enhance fall prevention programs. Available resources include workflow diagrams illustrating integration of screening into clinical encounters, screening and assessment tools with administration instructions, patient education materials in multiple formats and languages, clinical decision support algorithms, quality measurement specifications, and case studies of successful implementation. These resources have been validated across multiple healthcare settings and provide a strong foundation for program development. Implementation challenges and solutions vary by setting. In primary care, challenges include limited visit time, competing priorities, and fragmented referral pathways. Successful programs typically embed screening in nursing intake, leverage medical assistants or care coordinators for assessment components, and establish streamlined referral to community exercise programs. In emergency departments, implementation focuses on identifying patients presenting after falls, initiating brief assessment, and facilitating follow-up. Some implementations have described EHR integrated chatbot interventions connecting emergency department fall risk screening to community resources, demonstrating innovative approaches to bridging acute care and community follow-up. In long-term care, implementation requires attention to staffing patterns, staff turnover, and regulatory requirements. Studies of implementation strategy feasibility in home care services have demonstrated that co-created approaches involving implementation teams, competence development, and leadership support enhance adoption and sustainability. In hospital settings, fall prevention programs typically integrate with nursing quality and safety initiatives. Successful programs feature standardized risk assessment on admission, risk-based intervention protocols, fall event reporting and analysis, and staff education with competency validation. Even when fall prevention programs are well implemented at the organizational level, success ultimately depends on patient adherence to recommended interventions. Understanding barriers and facilitators at individual, interpersonal, and environmental levels enables development of strategies to enhance adherence. At the individual level, several factors influence adherence. Risk perception matters. Many older adults do not perceive themselves as at risk for falls, attributing prior falls to external causes like tripping on a rug rather than recognizing underlying vulnerability. Effective education helps patients understand their personal risk factors and the modifiability of fall risk. Fear of falling plays a paradoxical role. It can both motivate fall prevention engagement and undermine it through excessive activity restriction. Interventions should address fear of falling directly, building confidence through graded exposure to challenging but safe activities. Competing priorities can interfere. Older adults with multiple chronic conditions may perceive fall prevention as lower priority than management of symptomatic conditions. Framing fall prevention as essential to maintaining independence and managing chronic conditions may enhance motivation. Physical limitations may impede participation. Pain, fatigue, dyspnea, and functional limitations may impede participation in exercise programs. Programs should accommodate individual limitations through modification of exercises and flexible scheduling. Cognitive impairment creates special challenges. Individuals with cognitive impairment may have difficulty remembering recommendations, following exercise sequences, or recognizing the importance of fall prevention. Caregiver involvement is essential for this population. At the interpersonal level, healthcare provider recommendations carry significant influence. Brief, clear recommendations from trusted providers carry weight. Family support matters as well. Family members and caregivers can facilitate or impede adherence. Engaging families in fall prevention planning, particularly for cognitively impaired individuals, enhances intervention implementation. Social support for exercise is also important. Group exercise programs provide social motivation that enhances adherence compared with individual home-based programs for many older adults. The social dimension of programs such as Tai Chi, dance, and group strength classes contributes to their success. At the environmental and systemic level, program accessibility is a key factor. Transportation barriers, program location, scheduling constraints, and costs limit access to community exercise programs for many older adults. Offering multiple program formats, including group, individual, home-based, and technology-supported, expands accessibility. Healthcare system coordination affects implementation. Fragmented healthcare delivery impedes implementation of multifactorial recommendations. Care coordination, closed-loop referrals, and communication across providers enhance follow-through. Insurance coverage influences uptake. Reimbursement for fall prevention services varies. Programs such as the Medicare Annual Wellness Visit include fall risk assessment, and some Medicare Advantage plans cover evidence-based fall prevention exercise programs. Evidence-based strategies for enhancing adherence to fall prevention recommendations include several approaches. Shared decision-making engages patients in collaborative decision-making about intervention priorities, increasing commitment to selected interventions. Patients should participate in identifying which risk factors to address first and which intervention approaches align with their preferences. Prioritization acknowledges that addressing all identified risk factors simultaneously may overwhelm patients. Prioritizing 1 to 3 high-yield, modifiable factors initially with plans to address additional factors over time improves feasibility. Personalized care plans specify recommended interventions, follow-up appointments, and contact information for exercise programs, providing concrete guidance for patients and families. Motivational interviewing techniques help patients explore ambivalence about behavior change and develop intrinsic motivation for fall prevention activities. Follow-up contact, whether in person, telephone, or technology-mediated, reinforces recommendations, addresses barriers, and maintains engagement over time. Emerging technologies offer new modalities for fall risk screening, intervention delivery, monitoring, and communication. While the evidence base for technology-enhanced fall prevention is still developing, several applications show promise. Electronic health record integration facilitates several aspects of fall prevention programs. Clinical decision support through automated alerts can identify patients meeting criteria for screening or assessment, prompt clinicians to address fall risk during encounters, and flag high risk medications in prescribing workflows. Population health management using EHR data enables identification of patients with elevated fall risk who have not received screening or intervention, supporting proactive outreach. Documentation templates ensure consistent, complete documentation of screening results, assessment findings, and intervention plans. Care coordination through EHR based communication tools supports referrals, care plan sharing, and follow up tracking across providers and settings. Telehealth and remote monitoring expanded rapidly during the COVID-19 pandemic. Telehealth modalities can support remote assessment through video based observation of gait, balance, and functional mobility, though with limitations compared to in person evaluation. Structured protocols for telehealth fall risk assessment have been developed and validated. Exercise program delivery via video conferencing expands access for individuals with transportation barriers or geographic isolation. Protocols for telemedicine based fall risk programs have demonstrated feasibility of remote exercise and education delivery. Follow up monitoring through telehealth facilitates frequent low burden contact to assess adherence, address barriers, and monitor for falls or functional changes. Wearable sensors and accelerometers equipped with accelerometers and gyroscopes can monitor gait parameters, detect falls, and trigger alerts. The World Guidelines provide a conditional recommendation against routine use of wearable devices for fall detection in community dwelling older adults, reflecting limited evidence of benefit and concerns about false alarms, user burden, and cost. However, specific applications may hold promise. Reviews of artificial intelligence and technology for aging adults have described how AI-driven wearables enable continuous health monitoring, fall detection, and medication adherence support. Key benefits include early detection of gait changes predicting falls, automated emergency notification after fall events, and data collection supporting personalized intervention. Challenges limiting widespread adoption include user acceptance, as many older adults are reluctant to wear devices or find them burdensome, false alarms, as fall detection algorithms generate false positives that may desensitize users and emergency responders, battery life and maintenance requirements that may exceed user capacity, cost, as devices and monitoring services may not be covered by insurance, and evidence gaps, as randomized trials demonstrating that wearable devices reduce falls or fall-related injuries are lacking. Smart home technologies incorporating motion sensors, bed and chair sensors, and automated lighting can monitor activity patterns, detect falls, and modify the environment to reduce fall risk. Applications include activity monitoring through passive monitoring of movement patterns that can detect changes such as reduced activity, disrupted sleep, or altered gait that may presage functional decline or fall events. Fall detection through motion sensors and pressure mats can detect fall events and trigger alerts, complementing or substituting for wearable devices. Automated lighting systems that illuminate pathways when movement is detected may reduce nighttime fall risk. Medication reminders through smart dispensers and reminder systems may support medication adherence, including adherence to vitamin D supplementation. As with wearables, evidence demonstrating that smart home technologies reduce falls is limited, and implementation challenges including cost, installation complexity, user acceptance, and privacy concerns constrain adoption. Mobile health applications for fall prevention offer exercise instruction, fall risk self-assessment, medication tracking, and education. The World Guidelines note that mobile health applications should be guided by the P4 model: predictive, preventive, personalized, and participatory. Effective mobile health applications should provide evidence-based exercise content appropriate for older adults, adapt to individual functional level and preferences, track adherence and provide feedback, connect users with healthcare providers and community resources, and be accessible to users with limited technology experience. Artificial intelligence applications in fall prevention include fall risk prediction through machine learning models integrating clinical data, sensor data, and electronic health record information that may predict fall risk more accurately than traditional screening tools. Personalized intervention selection through AI systems may match patients to interventions most likely to be effective based on individual characteristics and predicted response. Exercise program adaptation through AI-driven exercise applications can adjust difficulty and progression based on user performance and reported outcomes. Natural language processing through AI chatbots can provide education, answer questions, and guide patients through fall prevention resources, as demonstrated by emergency department-based implementations. While these applications show promise, most remain investigational, and evidence from rigorous clinical trials is needed before widespread adoption. Sustained fall prevention program effectiveness requires ongoing quality monitoring and improvement. Process measures assess whether recommended fall prevention activities are occurring, including percentage of eligible patients screened for fall risk, percentage of at-risk patients receiving multifactorial assessment, percentage of high-risk patients referred to exercise programs, percentage of patients with documented medication review, and percentage of patients with completed home safety assessment. Outcome measures assess program impact, including fall rates expressed as falls per patient year or falls per 1,000 patient days, percentage of patients experiencing one or more falls, fall-related injuries including minor injuries, serious injuries, and fractures, fall-related emergency department visits and hospitalizations, and functional outcomes such as gait speed, balance scores, and activities of daily living function. Balancing measures assess unintended consequences, including activity restriction representing excessive caution-limiting function and quality of life, adverse effects from medication changes, patient and family satisfaction, and staff burden and burnout. Plan do study act cycles, lean methodology, and other quality improvement approaches support iterative program refinement. Key principles include using data to identify gaps and guide improvement, testing changes on small scale before broad implementation, engaging frontline staff in improvement design, celebrating successes and sharing best practices, and sustaining gains through standardization and ongoing monitoring. Fall prevention is not a one-time intervention, but an ongoing process requiring periodic reassessment and adaptation. Reassessment intervals should be tailored to risk level. Average risk patients warrant annual rescreening at minimum, with more frequent assessment if clinical status changes. Increased risk patients warrant reassessment every 6 to 12 months and after any fall event. High-risk patients warrants an after any fall event or significant clinical change. Beyond scheduled intervals, reassessment should occur when a patient experiences a fall, when new medical diagnoses or functional changes occur, when medications are significantly changed, when living situation or caregiver support changes, or when patient or family expresses concerns about fall risk. Long-term fall prevention management includes ongoing exercise to maintain strength, balance, and function, periodic medication review as regimens change, environmental reassessment as needs evolve, adaptation of interventions to changing functional status, and continued patient and family education. Now we arrive at our final module, which presents case studies for clinical application and decision-making. This module presents two comprehensive case studies representing diverse clinical scenarios across care settings. Each case study challenges you to integrate knowledge from all preceding modules, applying evidence-based screening, assessment, and intervention strategies to complex patient situations typical of clinical practice. The cases are written as complete clinical narratives, flowing from initial presentation through assessment, clinical reasoning, intervention planning, implementation, and outcomes. These case studies demonstrate application of the 7 learning objectives, illustrating how fall prevention principles translate into individualized patient care. I encourage you to consider how you would approach each case before hearing the clinical reasoning and intervention sections. Then reflect on how the presented approach aligns with or differs from your initial thinking. Our first case study involves a community-dwelling older adult with polypharmacy, depression, and mobility decline. Mrs. Eleanor Hoffman is a 78-year-old retired school teacher who presents to her primary care physician's office for a routine wellness visit. She lives alone in a 2-story home in a suburban neighborhood where she has resided for 42 years. Her husband passed away 18 months ago after a prolonged illness, during which Mrs. Hoffman served as his primary caregiver. She has 2 adult children who live approximately 90 minutes away and visit monthly. During the nursing intake, Mrs. Hoffman is administered the CDC Steady 3 key questions. She responds affirmatively to all 3. She fell once approximately 6 weeks ago while getting out of bed at night to use the bathroom. She acknowledges feeling a bit unsteady when walking, particularly on stairs, and she admits to some worry about falling, noting that she has stopped attending her weekly bridge club because she feels less confident driving and walking in unfamiliar environments. Mrs. Hoffman appears well-groomed but fatigued. She ambulates independently but slowly, using the furniture and walls for light support as she moves from the waiting room to the examination room. Her gait is notable for shortened stride length, mild forward flexion, and hesitancy at transitions. Review of Mrs. Hoffman's medical record reveals the following chronic conditions: hypertension for 15 years, type 2 diabetes mellitus for 12 years, osteoarthritis of bilateral knees and lumbar spine for 10 years, major depressive disorder diagnosed 14 months ago following her husband's death, gastroesophageal reflux disease, chronic insomnia, and osteopenia identified on DEXA scan 3 years prior. Her current medication list includes 12 medications: lisinopril, daily for hypertension, amlodipine, daily for hypertension, metformin twice daily for diabetes, glipizide for diabetes, sertraline daily for depression. Trazodone at bedtime for insomnia. Zolpidem at bedtime as needed for insomnia. Acetaminophen daily for pain. Meloxicam daily for arthritis pain. Omeprazole daily. Calcium carbonate twice daily for osteopenia. Vitamin D3 daily for osteopenia. She reports taking Zolpidem most nights because Trazodone alone does not help her sleep. She has not had her vitamin D level checked in over 2 years. Physical examination reveals vital signs with blood pressure of 138 over 78 millimeters of mercury seated and 118 over 70 millimeters of mercury after standing for 1 minute, representing a drop of 20 millimeters of mercury systolic consistent with orthostatic hypotension. Mrs. Hoffman reports feeling a little lightheaded upon standing but notes this is normal for her. Heart rate is 72 beats per minute and regular. Weight is 156 pounds, down 8 pounds from 1 year ago, and height is 5 feet 4 inches, giving a BMI of 26.8. Performance-based assessment yields the following results. Gait speed on the 4-meter walk is 0.72 meters per second, which is below the 0.8 meters per second threshold indicating impaired mobility. Timed up and go is 16.2 seconds, above the 12-second threshold suggesting elevated fall risk. 30-second chair stand yields 7 repetitions below age-adjusted norms. On the 4-stage balance test, she is unable to maintain tandem stance for 10 seconds, completing only 6 seconds before stepping out. Vision screening reveals corrected visual acuity of 20 over 40 in the right eye and 20 over 50 in the left eye. She wears progressive lenses that are 3 years old. Foot examination reveals mild hallux valgus bilaterally, dry skin with early fissuring at the heels, and intact sensation to monofilament testing. She is wearing slip-on canvas shoes with worn soles. The Patient Health Questionnaire 9 score is 12, indicating moderate depression despite current antidepressant therapy. The Falls Efficacy Scale International score is 32 on a range of 16 to 64, indicating moderate concern about falling that is affecting her daily activities. Cognitive screening with the mini-cog reveals normal results with 3 of 3-word recall and normal clock drawing, suggesting intact cognition. Mrs. Hoffman presents with multiple intersecting fall risk factors that place her in the high-risk category warranting comprehensive multifactorial intervention. Her risk factor profile includes intrinsic factors such as impaired gait and balance, with gait speed of 0.72 meters per second, tug of 16.2 seconds, and inability to complete tandem stance, lower extremity weakness with only 7 chair stands, orthostatic hypotension with a 20 millimeter systolic drop, visual impairment at 20 over 40 and 20 over 50, depression with elevated fear of falling reflected in an FESI first score of 32, and recent weight loss suggesting possible nutritional compromise. Medication-related factors include polypharmacy with 12 medications, use of multiple fall risk-increasing drugs including zolpidem, which is a Z drug, trazodone, which is a sedating antidepressant, sertraline, which is an SRI associated with hyponatremia and falls, and dual antihypertensive therapy contributing to orthostatic hypotension. The combination of trazodone and zolpidem is particularly concerning for nighttime fall risk. Glipizide poses hypoglycemia risk that could contribute to falls. Environmental and situational factors include living alone in a 2-story home with stairs, history of nighttime fall that was bathroom-related, and social isolation following her husband's death and activity restriction due to fear of falling. Psychological factors include moderate depression inadequately controlled on current therapy, activity restriction and social withdrawal driven by fear of falling, and recent bereavement with loss of social support. The fall that occurred 6 weeks ago at night while getting out of bed to use the bathroom is characteristic of medication-related falls, involving the combined effects of sedative hypnotics, orthostatic hypertension, and nocturia in a dimly lit environment. Based on comprehensive assessment, a tailored multifactorial intervention plan was developed in collaboration with Mrs. Hoffman. The first priority was medication optimization. The medication regimen required significant attention. After discussion with Mrs. Hoffman and consultation with her prescribing providers, the following changes were recommended. Discontinue zolpidem with tapering guidance given its strong association with falls and cognitive effects in older adults. Consider reducing trazodone or transitioning to sleep hygiene interventions. Evaluate antihypertensive regimen given orthostatic hypotension with consideration of reducing amlodipine dose, or switching to bedtime dosing. Review glipizide necessity given hypoglycemia risk, and consider transition to medication with lower hypoglycemia potential. And optimize vitamin D supplementation if deficient. Mrs. Hoffman expressed significant anxiety about discontinuing sleep medications. Using motivational interviewing techniques, the clinician explored her concerns, provided education about the connection between these medications and her nighttime fall, and developed a gradual tapering plan with close follow-up. The second priority was exercise program referral. Mrs. Hoffman was referred to a community-based Tai Chi program specifically designed for older adults, which meets twice weekly at a senior center 10 minutes from her home. Tai Chi was selected because it addresses balance, lower extremity strength, and fear of falling in an enjoyable group format that may help address her social isolation. The program runs for 12 weeks with option to continue. Transportation was arranged through a volunteer driver program. Additionally, she was provided with a home exercise program focusing on sit-to-stand exercises progressing from using arms to not using arms, single-leg stance practice at the kitchen counter, and heel-toe walking along a hallway. The third priority was environmental assessment and modification. A home safety evaluation by an occupational therapist was ordered. Given her nighttime fall history, priority recommendations would likely include nightlight installation along the pathway from bedroom to bathroom, grab bar installation in the shower tub and toilet area, evaluation of bed height and ease of transfer, assessment of stair safety including handrails, lighting, and contrast strips, and footwear recommendations including supportive slippers for nighttime. Mrs. Hoffman was advised to replace her worn slip-on shoes with supportive, properly fitting shoes with non-slip soles and secure fixation. The fourth priority was vision correction. Referral to ophthalmology was placed for comprehensive eye examination given reduced acuity and outdated prescription. She was counseled about the potential benefit of single-lens distance glasses for outdoor walking rather than her progressive lenses. The fifth priority was depression management. Given persistent moderate depression despite sertraline therapy, psychiatric consultation was recommended to optimize antidepressant management. The fear of falling and activity restriction were addressed as both consequences and perpetuating factors of her depression. Reconnecting with social activities such as bridge club and church group she previously attended was encouraged as part of behavioral activation. At 6-week follow-up, Mrs. Hoffman reported meaningful progress. Zolpidem had been discontinued with only mild initial sleep disruption that improved with sleep hygiene measures. Amlodipine was reduced to 2.5 milligrams, and repeat orthostatic measurements showed systolic drop of only 8 millimeters of mercury without symptoms. Vitamin D level returned at 18 nanograms per milliliter, which was deficient, so supplementation was increased to 2,000 international units daily. She had attended 8 Tai Chi classes and reported enjoying the social aspect as much as the exercise. She noted feeling more confident on her feet and had resumed driving to local destinations. The occupational therapist completed home assessment, and grab bars had been installed, nightlights placed, and bed risers added to facilitate transfers. Ophthalmology evaluation revealed early cataracts in both eyes, not yet surgical, and updated her prescription. New glasses with single-vision distance lenses for walking had been ordered. At 3-month follow-up, Mrs. Hoffman had experienced no falls. Gait speed had improved to 0.89 meters per second, tugged to 13.1 seconds, and she successfully completed 10-second tandem stance. PHQ-9 score had decreased to 7, indicating mild depression. FES1 score had improved to 24, reflecting reduced fear of falling. She had returned to her bridge club and resumed attending church services. She will continue with Tai Chi by transitioning to a maintenance class, receive annual fall risk reassessment, and undergo ongoing monitoring of depression and medication regimen. Our second case study involves a long-term care resident with dementia and recurrent falls. Mr. Robert Chen is an 84-year-old man residing in a skilled nursing facility for the past 14 months. He was admitted following a hip fracture that occurred during a fall at home, where he had been living with his wife who could no longer safely manage his care given his progressive cognitive and functional decline. His wife visits daily and remains highly involved in his care. The nursing staff has requested a comprehensive fall risk evaluation because Mr. Chen has fallen 6 times in the past 3 months, with increasing frequency representing 3 falls in the past 4 weeks alone. None of these falls resulted in serious injury, but the most recent fall produced a forehead laceration requiring sutures. Falls have occurred at various times of day but cluster around care transitions, getting out of bed, transferring to and from his wheelchair, and during toileting. Mr. Chen is observed in his room, seated in a wheelchair. He appears pleasant but confused about the date and location. He recognizes his wife but cannot recall the names of nursing staff who have cared for him daily for over a year. He attempts to stand from his wheelchair without waiting for assistance, requiring staff intervention to prevent falling. Mr. Chen's medical history includes Alzheimer's disease diagnosed 5 years ago and now at moderate to severe stage, coronary artery disease with prior myocardial infarction, atrial fibrillation, hypertension, benign prostatic hyperplasia, and the right hip fracture 14 months ago that is status post-open reduction internal fixation with subsequent inpatient rehabilitation. His current medications include Donacil 10 mg daily for dementia, Memantine 10 milligrams twice daily for dementia. Apixaban 5 milligrams twice daily for atrial fibrillation. Metoprolol succinate 50 milligrams daily for rate control and hypertension. Lisinopril 10 milligrams daily for hypertension. Tamsulosin 0.4 milligrams at bedtime for benign prostatic hyperplasia. Quidapin 25 milligrams at bedtime for agitation and sleep. Lorazepam 0.5 milligrams twice daily for anxiety and agitation. Oxycodone 5 milligrams every 6 hours as needed for pain. Docusate sodium 100 milligrams twice daily for constipation. And acetaminophen 650 milligrams 3 times daily for pain. Review of medication administration records reveals that lorazepam has been administered 8 times in the past 2 weeks, and oxycodone has been given 3 to 4 times daily. Quidapin was initiated 2 months ago to address evening agitation known as sundowning that was distressing to staff and other residents. Formal cognitive testing confirms moderate to severe dementia with a Montreal Cognitive Assessment score of 9 out of 30. Mr. Chen is unable to follow multi-step commands reliably but can follow simple one-step instructions with demonstration. He does not recall falling and cannot provide history of symptoms preceding falls. Interview with nursing staff and review of incident reports reveals the following pattern. Mr. Chen frequently attempts to stand and walk independently despite requiring assistance. He does not use his call light, appearing to have forgotten its purpose, and does not wait for help. He becomes agitated when physically restrained or when staff attempt to redirect him from standing. Falls have occurred when he stands abruptly from bed or wheelchair, loses balance, and is unable to recover. Physical examination reveals blood pressure of 142 over 84 millimeters of mercury seated and 128 over 78 millimeters of mercury standing, representing a 14 millimeter systolic drop that is asymptomatic, though symptom report is unreliable given cognitive impairment. Gait observation shows wide-based, shuffling gait with shortened steps, requiring contact guard assistance and demonstrating retropulsion on turning. Lower extremity strength is difficult to assess formally due to comprehension limitations but appears globally reduced. Range of motion shows reduced hip flexion on the right surgical side and bilateral knee flexion contractures of approximately 15 degrees. Skin examination reveals a stage 1 pressure injury on sacrum and healed surgical incision on right hip. Medication review using stop-fall criteria identifies multiple fall risk-increasing drugs. Quidapine, which is an antipsychotic, lorazepam, which is a benzodiazepine, oxycodone, which is an opioid, tamsulosin, which is an alpha blocker with orthostatic potential, and metoprolol, which is a beta blocker. The anticholinergic burden score is 3, calculated from quidapine at 1, oxycodone at 1, donepezil at -1 being cholinergic, tamsulosin at 1, and lorazepam at 1. Indicating moderate anticholinergic load in a patient with dementia. The combination of quidapine, lorazepam, and oxycodone creates substantial cumulative sedation risk. Notably, quidapine was added recently, 2 months ago, and fall frequency has increased during this period. Mr. Chen represents a complex fall prevention challenge characteristic of long-term care populations. His falls are driven by the interaction of several factors. Cognitive impairment and behavioral factors are paramount. Moderate to severe dementia prevents him from recognizing his limitations, remembering to call for help, or following safety instructions. His attempts to ambulate independently reflect preserved motor initiation without preserved judgment, which is a particularly dangerous combination. The impulsive standing behavior is characteristic of frontal executive dysfunction in dementia. Medication burden is significant. The medication regimen includes multiple high-risk agents. The recent addition of quidapine temporally correlates with increased fall frequency. The as-needed benzodiazepine and opioid are being administered frequently, likely contributing to sedation and further cognitive impairment. Research demonstrates that antipsychotic doses in the 24 hours preceding falls are associated with fall events in dementia inpatients. Physical factors are also contributing. Gait abnormalities, including shuffling and retropulsion, lower extremity weakness, joint contractures limiting mobility, and residual effects of hip fracture all contribute to impaired balance recovery when perturbations occur. Environmental and care process factors play a role as well. Falls clustering around care transitions suggest opportunities for environmental and process modifications. The wheelchair may not be optimally positioned or fitted. Bed height and configuration may facilitate unsafe transfers. Importantly, Mr. Chen's anticoagulation with apixaban substantially increases the consequent severity of any fall, particularly head trauma. The recent forehead laceration, while not resulting in intracranial hemorrhage, signals elevated risk for catastrophic outcome with future falls. Given the complexity of Mr. Chen's presentation and the limitations imposed by his cognitive impairment, intervention focuses on environmental modification, medication optimization, staff training, and injury mitigation rather than patient-directed education or exercise. The first priority was medication review with prescriber engagement. A case conference was convened including the attending physician, consultant pharmacist, director of nursing, and Mrs. Chen. The following medication changes were proposed. For quidapine, a taper and discontinuation was recommended. The temporal relationship between quidapine initiation and increased falls was discussed. Non-pharmacological approaches to evening agitation were proposed as alternatives, including structured evening activities, reduced stimulation, consistent routines, and redirection techniques. If agitation remained unmanageable, a lower dose or alternative agent might be considered after a trial off the medication. For lorazepam, the goal was to minimize benzodiazepine use. Lorazepam should be reserved for severe agitation not responsive to non-pharmacological intervention. Staff education emphasized that benzodiazepines worsen confusion and fall risk in dementia. For opioid use, reevaluation of necessity was recommended. Mr. Chen's pain source and severity were unclear. A trial of scheduled acetaminophen with opioid reserved for breakthrough pain was recommended, with careful observation for pain behaviors. For tamsulosin, a review was recommended. Given orthostatic blood pressure changes, the team considered whether tamsulosin remained necessary or whether dose reduction was possible. Mrs. Chen was engaged in this discussion. She expressed concern about her husband's comfort if pain medications were reduced, but understood the fall risk implications. Shared decision-making resulted in agreement to proceed with gradual changes and close monitoring. The second priority was environmental and equipment modifications. These included bed positioned at lowest height with floor mats alongside, pressure-sensing bed alarm to alert staff when Mr. Chen attempts to rise, wheelchair evaluated by physical therapy for proper fit with anti-tip bars added, hip protector garments ordered given recurrent falls and anticoagulation, non-slip footwear with secure fixation replacing current loose slippers, and room arrangement reviewed to minimize obstacles. The third priority was care process modifications. These included a toileting schedule implemented every 2 hours while awake to reduce urgency-driven attempts to stand independently, staff assignment adjusted to ensure consistent caregivers familiar with Mr. Chen's patterns, care plan updated to specify two-person assist for all transfers, and communication board at bedside with simple visual reminders, though effectiveness would be limited given cognitive status. The fourth priority was staff education. Nursing staff received education on fall risk factors specific to dementia, including impulsivity, impaired judgment, and inability to learn from falls. Non-pharmacological management of agitation, recognition of medication-related sedation and cognitive effects, proper use of bed alarms as alerting devices rather than restraints, and transfer techniques for patients with impaired weight-bearing and cognition. The fifth priority was family engagement. Mrs. Chen was provided education about fall risk factors and the intervention plan. Her daily visits were leveraged for supervised ambulation with physical therapy guidance, providing both exercise benefit and meaningful engagement. She was counseled about realistic expectations. Complete fall elimination may not be achievable, but fall reduction and injury prevention are goals. Over the subsequent 3 months, Mr. Chen's fall frequency decreased from 6 falls in 3 months to 2 falls in 3 months, representing a meaningful reduction though not elimination. Neither fall resulted in injury. Quidapine was successfully discontinued over 4 weeks. Evening agitation initially increased but responded to structured activities including music therapy, an evening snack routine, and consistent staffing. Lorazepam use decreased to twice in 3 months from 8 times in 2 weeks previously. Oxycodone was reduced to once or twice weekly for apparent pain episodes. The bed alarm has been effective in alerting staff to Mr. Chen's attempts to rise, allowing timely intervention. Hip protectors are worn consistently during the day. Staff report improved confidence in managing his care. Mrs. Chen expressed gratitude for the team's efforts and feels more informed about her husband's condition and care. She continues daily visits and participates in supervised walking, which physical therapy has incorporated into a maintenance mobility program. Mr. Chen remains at elevated fall risk due to his underlying dementia and functional impairment, and falls cannot be entirely prevented in this population. The goal has shifted appropriately from fall elimination to fall reduction and injury mitigation, with attention to quality of life and dignity. This brings us to the conclusion of our course on geriatric fall prevention, assessment, and care. Throughout this course, we have covered the epidemiology and risk factors for falls, the tools and approaches for systematic screening across care settings, the components of comprehensive multifactorial assessment, evidence-based interventions including exercise, environmental modifications, and multifactorial programs, medication review and pharmacological considerations, implementation strategies and technology integration, and finally, the application of these principles through detailed case studies. I hope you now feel equipped to identify the comorbidities that increase fall risk in older adults, select appropriate fall risk screening tools for your specific care setting, recognize the essential components of a comprehensive fall risk assessment, identify effective interventions for reducing falls in high-risk older adults, recognize fall risk increasing medications using validated criteria, apply strategies to integrate fall prevention protocols into clinical workflows, and select tailored fall prevention interventions for older adults with complex needs. Remember that falls are not an inevitable consequence of aging. With systematic, evidence-based approaches to screening, assessment, and intervention, we can substantially reduce fall rates and improve outcomes for the older adults we serve. Thank you for your commitment to this important work in promoting safer, more independent lives for older adults. We will now review the exam questions to solidify your understanding of fall prevention assessment and care for older adults. Question 1. According to meta-analytic evidence presented in the course, older adults with dementia experience fall rates how many times higher than cognitively intact peers? The correct answer is C, 2 to 3 times higher. Rationale: meta-analytic evidence consistently demonstrates that older adults with dementia experience fall rates 2 to 3 times higher than cognitively intact peers, with annual fall incidence of 60 to 80% in community-dwelling individuals with moderate to severe dementia. Question 2. Which screening approach does the CDC Study Initiative recommend as the foundation for fall risk identification in community settings? The correct answer is B, 3 key questions. Rationale: the foundation of study screening is the 3 key questions, which can be administered in under 1 minute. These questions ask about falls in the past year, feeling unsteady when standing or walking, and concerns about falling. An affirmative response to any question indicates elevated fall risk warranting further evaluation. Question 3. According to contemporary fall risk assessment frameworks presented in the course, how many key domains require systematic evaluation in a comprehensive assessment? The correct answer is D, 7 domains. Rationale: contemporary fall risk assessment frameworks converge on 7 key domains requiring systematic evaluation: strength, gait and balance impairment, medication use and fall risk increasing drugs, postural hypotension, foot and footwear problems, vision impairment, osteoporosis and vitamin D deficiency, and home safety and environmental hazards. Question 4. What minimum total exercise dose has been identified in meta-analytic evidence as necessary for demonstrating consistent fall prevention benefit? The correct answer is A, 50 hours over the intervention period. Rationale: programs delivering a minimum of 50 hours of exercise over the intervention period demonstrate more consistent benefit than lower dose programs. This threshold can be achieved through various frequency and duration combinations, such as approximately 3 hours per week over 4 months. Question 5. Which medication class demonstrates the strongest and most consistent association with fall risk in older adults? The correct answer is A, psychotropic medications. Rationale: psychotropic medications demonstrate the strongest and most consistent associations with fall risk, reflecting their combined effects on central nervous system function, postural reflexes, and alertness. This category includes benzodiazepines, Z-drugs, antidepressants, and antipsychotics, with odds ratios ranging from 1.4 to 2.3 for falls. Question 6. Which of the following is identified as essential for successful implementation of fall prevention programs? The correct answer is B, leadership support with resource allocation and accountability. Rationale: leadership support is essential for successful implementation. Organizational leaders must prioritize fall prevention as a quality and safety objective, allocating resources, establishing accountability, and communicating the importance of systematic fall prevention to all staff levels. Question 7. In the case study of Mr. Chen, a long-term care resident with dementia and recurrent falls, which intervention approach was prioritized given his cognitive impairment? The correct answer is C, environmental modification, medication optimization, and injury mitigation. Rationale: given the complexity of Mr. Chen's presentation and the limitations imposed by his cognitive impairment, intervention focused on environmental modification, medication optimization, staff training, and injury mitigation rather than patient-directed education or exercise. This approach recognizes that cognitively impaired patients cannot reliably follow safety instructions or participate in standard exercise programs. Question 8. According to Cochrane Reviews, by what percentage do home fall hazard interventions reduce fall rates when targeted to individuals at higher baseline fall risk? The correct answer is C, 38%. Rationale Cochrane Reviews demonstrated that when targeted to individuals at higher baseline fall risk, such as those with prior falls, recent hospitalization, or support needs for daily activities, home hazard interventions reduced fall rates by 38%, with a rate ratio of 0.62. This is high certainty evidence and substantially more effective than when offered to unselected populations. Question 9. At what threshold does polypharmacy become clinically significant for fall risk, according to the course material? The correct answer is B, 5 or more medications. Rationale polypharmacy is conventionally defined as concurrent use of 5 or more medications. At this threshold, the cumulative risk becomes clinically significant, with odds ratios of 1.4 to 1.8 for falls. Excessive polypharmacy is defined as 10 or more medications, which escalates fall risk even further. Question 10. What gait speed threshold indicates impaired mobility associated with elevated fall risk? The correct answer is D, below 0.8 to 1.0 meters per second. Rationale walking speed below 0.8 to 1.0 meters per second is consistently associated with elevated fall probability, and the relationship demonstrates a graded dose-response pattern. Slower gait speed correlates with progressively higher fall rates. Gait speed has emerged as a robust and easily assessed marker of fall risk. This concludes our exam review for the Fall Prevention Assessment and Care course. Remember that falls are not an inevitable consequence of aging, and evidence-based, multifactorial interventions can significantly reduce fall risk in older adults across all care settings.